So this is like a multivitamin tablet which will boost your insight, and you will definitely have some clear vision in beyond 2020. So let me have a privilege to introduce my friend Dr. Ajit Kulkarni with the opening batsman, and he's going to talk on post-COVID sequelae. Dr. Ajit Kulkarni is done his MD chest from one of the most reputed Mondes hospitals, which is the first of its kind in India. He is the co-promoter director of National Hospital, Kolhapur.
Am I audible? Yeah. Good morning, everybody. I am Dr. Ajit Kulkarni. I am going to speak on post-COVID issues in the clinical practice. As Dr. Shirke, our president, has told that we are all suffering from this COVID for last 1 year or so. Fortunately for us now, the new case, new diagnostic cases are getting less and less. And for last 1 week or so, the death toll in Kolhapur is almost zero. Otherwise, we had a frightening situation. We almost used to have thousands of cases diagnosed per day and almost 30 to 50 cases death rate per day. Now, maybe because of the social distancing or the mask or hand washing, we are getting less number of cases now. But if you go to the individualized management of cases, we are still getting good number of cases which have got extensive pneumonias, extensive ARDS. They require intubation and ventilation. They require ECMO kind of management. And as the story is getting unfolded, the COVID has got a multifaceted issues. Let us go to these issues which are now getting unfolded now. You have got a severe cytokine storm leading to the rapid multiple organ dysfunctions. You have a Th1 kind of a pathological response, meaning by that you have got a cellular immunity upfront coming and probably the immunity is going haywire and you have got an immune storm. The second infection is possible and we have reported a couple of cases which are second time infected. And this was our preliminary experience from the Wuhan. We were not scans. There are multiple shadows on CT scans, and now we know that these are the COVID pneumonias. This is the extensive pneumonias which happened after 15 or 16 days of one cases. And now we know that these are the cases which are likely to go in ARDS, and these are the people who are likely to have a crippling pulmonary fibrosis also. We know that 80% of the cases are milder, 15% cases are likely to have a severe kind of a pneumonia, and 5% people are critical, which are likely to go in ICU and require all kinds of lung transplants. But today, what we know is, even though 80% people who are mild, who don't have CT scan findings, are likely to progress into a multisystemic dysfunctions. This was the initial treatment plan, which has been endorsed by the ICMA. One month. In phase, had a viral response patient anospan or not, they show and people who got a high viral load and they are treated with remdesivir, favipiravir, and some people also receive the cholesterol. People were likely to go where they have and destroy spiritual taste, hypox going this way. And then we are getting people of their COVID treatment from the hospital are likely to come back to the hospital with multiple dysfunctions. I am presenting few of the cases to you. Now, this is 40 years gentleman who had been in the hospital for COVID pneumonia. Got I think I am audible now to everybody. Presented with acute shortness of breath, he was profusely sweating, diaphoretic, and on arrival immediately, even in casualty, we did his echocardiogram to understand are there any clinical signs of acute left ventricular dysfunction. Surprisingly, he had this echo. We showed D kind of an LV. The RV is dilated, the LV is getting compressed, even though there is a hypertrophic LV. Now, this is a classical presentation on echo of an acute massive pulmonary embolism. We had a time because he was not in that hypotensive state, so we did his CT pulmonary angiogram, and it showed a dilated right ventricle, which was also picked up on echo, and CT pulmonary angiogram showed a big thrombus in the right pulmonary artery. Now, these are the cases which can be mild to moderate, but are likely to again come back with massive vascular inserts. And there are n number of case reports, and there is a lot of discussion about this pulmonary embolism or the vascular inserts after COVID. And acute pulmonary embolism is a potential complication of even mild COVID cases and may occur late in the course of disease. When the symptoms related to the acute illnesses are already disappeared, people are likely to come out with acute presentations. And there is a late pulmonary embolism, and this is a case study by multiple cohort studies. We showed that there are cases of massive pulmonary embolism, acute myocardial infarcts, which are likely to come after they have been recovering from the COVID pneumonias. Learning point is COVID-19 infection is associated with the frequent thrombotic events. It can be pulmonary, it can be cerebral, it can be cardiovascular. And procoagulative status is the trigger for the persistent inflammatory phase of the infection. And even though you anticoagulate, the standard protocol nowadays to give an oral anticoagulant to everybody. But irrespective of that, people are likely to get a multiple vascular inserts because the pro-inflammatory state is not yet over. This is point number one. Point number two, people who are discharged from the hospital with such kind of pneumonias, they are in the hospital for 10 days, they are not that hypoxic, or they are going in to home with a home oxygen and whatever the treatment they are receiving. They are hypoxic, but still can be able to manage in their home because this pneumonia is going to take a long time. But even after 15 days, they are likely to come back with a progressive worsening of breathlessness, and even after 15 days, the pneumonias are likely to get far, far worse. Now, this is a CT presentation of an extensive pneumonia, which is likely to go in pulmonary fibrosis because there is an interstitial thickening. This is what is called the typical crazy paving pattern of COVID. These are the people who are likely to have a pulmonary people because they are pulmonary people. So this is likely to happen even in 15-20 days after COVID. Case. A patient is mildly symptomatic. He has a small ground glass CT scan, COVID test positive, RT-PCR positive, treated properly with remdesivir and whatnot, and went home without any symptom. He was asymptomatic, regained his health, and came back again into the hospital, into his work for his routine work. And after 15 days, he had a high grade of fever, He had a spike of 103 degree Fahrenheit, and within hours of time, he started getting this massive rash all over the body. He had a high grade fever. His inflammatory markers started showing very high. His CBC showed a lymphopenia to the tune of 2%. He had a very severe neutrophilia. He had a thrombocytopenia, and all these features were looking like whether this is a cytostorm, which is secondary, which is happening after 4 to 5 weeks of COVID. So these cases show us that there is a rampant presentations of inflammatory response syndromes or multiple organ dysfunctions even after the COVID is said to be cured. Therefore, the statement today is the care of patients with the COVID must not stop at 2 weeks, but should continue with the judicious use of medications and the supportive treatment. And today the WHO has come out with the bulletin that there are long-term effects of COVID, and each and every individual, even though he is ill, should be assessed for long-term effects. And this is a telephonic survey which is done in USA of more than thousands of cases and understood what are their symptoms which have and almost 35% of say that congestion and shortness of breath. They have still loss of taste. What we see in India is today is almost everybody has a fatigue. They have muscular weaknesses. They have a congestion and vague. Even though we say that these are the vague symptoms, because we know that this is an inflammatory syndrome which is then going to happen even after the COVID is cured. This has a meaning because eventually
Oh,
No, we can see slides and everything. So we are all saying
I just put them as a. Yes.
unmute जरा.
नाही नाही हा झालं झालं झालं. Yes.
Continue.
Continue.
I'm really sorry for these technical issues because I'm getting muted repeatedly. I'm getting this internet connections low again. So I will continue. Now, these early and late complications of COVID are because of three reasons. There is direct viral invasion into the various organs. Initially, what we knew was it's a lung pathology because ACE receptors are predominantly seen over the pneumocyte to alveoli. Therefore, the pneumonia was predominant. but ACE receptor are widely reciprocated in multiple organs, predominantly brain, GI, kidney, and heart, and they are also been predominantly seen over the endothelium vessel. So there is endotheliitis, there is small clot formation everywhere, and there is angiogenesis leading to small infarcts and multiple organ dysfunctions. And there is what is called the Th1 related immune response because there is lot of macrophages and mass activation leading to cytokine storm. So these are the three reasons which are responsible for late complications of COVID. Will not go into the details of this pathogenesis, but now there are studies, and this early study, which is an autopsy study, which is done after the 7 days of a COVID, and people they had tried to correlate what is happening in the lungs with H1N1 infected days, ARDS, and what they have found that the alveolar capillary microthrombi were 9 times prevalent as compared to the H1N1 days. So the microthrombosis, the angiogenesis, and the endothelitis is almost 9 to 10 times severe as compared to H1N1, and there is as compared to H1N1 influenza, the angiogenesis is almost 2.7 times more. So these are the issues which are the late complications, and there is endothelial expression. And as I said, there is a long-term immunological consequences. Once the virus gets into the cell, it produces an immune response. It produces macrophages, it produces mast cells, and they produce a lot of inflammatory cytokines. They produce IL-6, TNF-alpha, as well as histamines and prostaglandins. In few cases, this inflammatory response is uncontrolled, and then it gets spill over to multiple organs because the ACE receptors are there located everywhere. So in addition to the respiratory symptom, you start getting cardiovascular symptoms, renal symptoms, hepatic injury, and they find coagulopathy and sometimes shock. This is usually accompanied by lymphopenia, and lymphopenia is taken as a prognostic or a mortality marker, neutrophilia, thrombocytopenia, high-grade fever, high ferritin levels, and they start getting a skin presentation like a severe rashes. It shows elevation of inflammatory markers including CRP, LDH, ferritin levels, and also clotting factors like D-dimer. So if you find a person which is treated for COVID, but coming out with this presentation of a high-grade fever or start getting fever and rash, you are supposed to, even though COVID is tested negative or his RT-PCR is negative, he is likely to have a post-COVID complication or what is called as a late onset immune response and likely to have a multi-organ dysfunction. It is extended to 4 months, and the presentations are in the post-COVID in the early 2 weeks, you are likely to have a dysregulated host response. Predominantly, you are likely to get a respiratory symptoms. They get more breathless. They get more aggressive pneumonia. They start getting cardiovascular symptoms like breathless. They may present with myocarditis and congestive heart failures, but they also start getting dermatological presentations and GI. By this time, still their RT-PCR may be positive because it's hardly 14 days or so, but their antibodies start coming positive. They may show IgM positivity or even IgG positivity. But in the late consequences, even though there is a dysregulated response and there is a hyperinflammatory response syndrome, the presentations are a little different. You start getting predominantly dermatological presentations, you start getting severe rashes, patients are toxic, high-grade fever, they may have a myocarditis and severe tachycardia, they may show evidences of generalized edema because the vessels are leaking, and within couple of hours, they show deranged LFTs, deranged activities, and all the inflammatory markers, including D-dimer and LDH and CRP, ferritin levels are going to be very, very high. Now, you don't know the reasons for this inflammatory responses syndrome, but it is there. And lab in this case is uncertain. We all believed in RT-PCR, but it in acute infective phase, in this late consequences, after 4 weeks, you may not get a positive, RT-PCR. You may get antibodies positive, you may get anti-IgM positive or IgG positive. So even though you get an IgG positive and the patient is showing these responses of dermatological to RS and CVA, you are supposed to take as a post-COVID complications. Only caveat is we have seen people who presents with this kind of a presentation have an acute viral presentations like a chikungunya and dengue. So you should be little wise enough to understand that, and you should be able to differentiate between these two features of immune response versus an acute arbovirus infections. And what we should know in a long-term health problems in COVID-19 is it is there. People are likely to come back to you again in your OPD because of various presentations. Don't ignore them. And the organs which are affected probably are heart, probably are the lungs, and the early manifestations will be a progressive worsening pneumonias or ARDS or lung fibrosis. You start getting heart issues of a congestive heart failure or arrhythmias. You may start getting people with dementia like presentation, or you can start getting like anosmia, memory impairment, or they may get a major vessel thrombotic events like stroke. Everybody comes with anxiety and depression and post-traumatic stress disorders, and almost more than 80% of people, they have joint pains, they have a fatigability, they have muscular weaknesses. So these people are going to come back again and again, and the pathognomic features of all these issues are a thromboembolism, which is widespread everywhere. So you should not ignore all these presentations. So what we are supposed to see in post-COVID OPDs are, you must assess clinically, at least in the primary setting of lungs, how they are going to behave, what is their presentation. If the patient has got no pneumonias on first presentation, they are likely to get pneumonias worsening even after 10 or 14 days of, so you are likely to have a clinical examination and HRCT if possible. Cardiovascular should be looked very keenly. Brain, peripheral nerves, because there are presentations like a Guillain-Barré syndrome, and coagulation defects, which is the hallmark of these post-COVID complications. You are likely to get a larger clots and may present with the MI or pulmonary embolism, and you also get capillary microemboli. So people will not be present like an acute organ failure like microinfarct, but because there are small capillaries blocked because of microthrombi, the organs are getting poorly supported with their circulation. So they are likely to get a myocarditis, they are likely to get congestive heart failure, they are likely to get an acute kidney failure, they are likely to get an acute hepatic failure. So multiple organ dysfunctions because of the microthrombi is quite possible. Fatigue and muscular weakness is common, and infections are the cornerstone because people with COVID are likely to get multiple infections, predominantly fungi or viruses. Lungs. And as we have said that this COVID-19 is a lung disorder, it's true, because 5% of people who are this moderate to severe are likely to get lung pneumonias. They are likely to get worsened day by day. We do CT scans even after 15 days or 20 days, and within that period of time, their CT scan have worsened like anything. So probably the post-COVID lung fibrosis is likely to have a tsunami effect after this COVID. And this is the pathogenesis of this lung fibrosis. We'll not go into the details. But even if you are sent the patient with this kind of CT score presentation at the time of discharge, there are hardly 10 or 15 score on discharge. Within 15 to 20 days, they are likely to present with massive pulmonary fibrosis. And this guy has got a multiple fibrotic bands. He has consolidations. he has interstitial thickening, he has ground glass opacities, he has what is called as the crazy wave pattern. So this guy is likely to go in the post-COVID fibrosis and probably will require a management for years together. Now, this is a frightening situation. What is the natural history of this post-COVID fibrosis? The data is limited, but people, almost 80% of population is likely to improve, and that's the most common presentation. 3 months before, we had heard about this fibrosis, and people are returning back to the OPD with fibrosis, and we were all worried whether all those COVID people with the shadows on CT scans are likely with the pulmonary fibrosis. After 3 months today, we have understanding that most of them they improve, and data suggests that 80% of these people who have shadows on CT scans are likely to improve in their pulmonary fibrosis. People are likely to remain static, but this is a less common. And 5% of population are likely to deteriorate, and they are going to have a progressive pulmonary fibrosis, and they are going to be pulmonary cripple, and probably they will be labeled as post-COVID interstitial lung diseases. Now, these are the people who require oxygen treatment for a long time, and there is a low role of antifibrotic drugs in these cases. Cardiovascular. As we said, cardiovascular complications are hidden. We just concentrate on the lungs. But as there is a viral invasion into the multi-system, predominantly in the lung, the inflammatory cascade is lit up. There is a T cell involvement, there is a mast cell involvement, and there is cytokine release. This IL-6, IL-7, IL-22, TNF-alpha is likely to have an inflammatory cascade which is not controlled sometimes with the current body system, and they are going into the hyperinflammatory response syndrome. The viral invasion also is there in the myocardium, because myocardium has got a lot of ACE2 receptors, and this viral invasion in the myocardial cell causes myocarditis. This will again be doubled with this cytokine stamp, and this myocarditis effectively goes into the congestive heart failure and arrhythmias. So if you get a person with a congestive heart failure, even after 3 to 4 months of COVID well treated, you should think of post-COVID complications. And our conventional thinking of congestive heart failure is to go for management as a CHF, go for angiography, see whether there are any major blocks. Yes, that is to be done, but there are small vessel involvement, endotheliitis of the myocardium, coronary capillaries, and this microvascular dysfunction leading to MIs and congestive heart failure is quite common. So these cases which are post-COVID probably are post-inflammatory or hyperinflammatory, and their inflammatory response has to be tackled properly. Neurological. Virus enters brain by breaking the blood-brain barrier. It also enters via the olfactory system across the cribriform plate. ACE2 receptor presents on the cerebral endothelial cells, as endothelial cells has got a tremendous ACE2 receptor presentation. That's why there is entry of these viruses into the endothelial cells of cerebral circulation. ACE2 causes an uncontrolled blood pressure, and probably the reason for the predominant cerebral vascular accidents. And coagulopathy, microthrombi, vasculitis, endothelitis causes arterial venous thrombosis. These multifactorial effects on the neurology causes multiple presentations of neurologic COVID, which is post-COVID, and altered sensorium, confusion, coma, encephalopathy, meningoencephalitis, and cerebrovascular accidents are predominant presentations. Cerebral venous thrombosis, neuropathic pain, peripheral neuropathy, muscular weaknesses, and Guillain-Barré syndrome. Infections. Post-COVID infections is quite a common entity. What we have seen that a COVID probably doesn't make other influenza infections to come in, but bacterial infections are common, though they are not as common as fungi. Bacterial infections are hardly 0.5 to 1%. Fungal infections are almost to the tune of 50%. And most common is the aspergillosis. Rarely you start getting candidiasis. And your CT scan findings, because of the COVID pneumonias, cannot differentiate fungal pneumonias, aspergillosis from COVID pneumonias. Bacterial infections are Pseudomonas, MRSA, or Stenotrophomonas. Secondary infections sharply increases the mortality and morbidity. Severe COVID patients have a high incidence of invasive aspergillosis, and it's our common practice now, and it's a protocol now that every person who is not getting well with the COVID or shows persistent or worsening shadows on the CT scan, we send their serum galactomannan or if possible sputum galactomannan to understand is there invasive aspergillosis. And cutout point of 0.5 is taken as a indication of invasive aspergillosis. 37% of a COVID ventilated people will have a invasive aspergillosis. Inverse is more common, the steroids, diabetes, and tocilizumab. Anti-ILSS management probably will more trigger the invasion of aspergillosis. Damage to the respiratory endothelium, defective mucociliary clearance, and the local immune paralysis are the reasons for the invasive aspergillosis. Viral infection. And as I said, post-COVID viral infections are increasingly evident. Probably we are having a seasonal infections, but very rare to find influenza. What we have commonly seen are the arbovirus-related infections like chikungunya and dengue. And chikungunya presents with a devastating presentations. People are presenting with a very high grade fever. Within couple of hours time, they are getting a severe rashes. They have a severe arthralgic pain. They are bed bound. And because it's an inflammation with the virus, all the inflammatory markers are severely raised. The worrying issue in chikungunya is it also causes lymphopenia to the tune that it may go up to 0 or 1%. And as we know that the post-inflammatory response syndrome also causes lymphopenia in COVID. So the lab features are exactly similar to that of post-COVID hyperinflammation response syndrome. Chikungunya IgM may not be coming positive in the days, in early days. So probably the RT-PCR chikungunya becomes an answer for you. So you have to be little wise in managing this arbovirus infection. If you get a dengue, practically the presentation is same, but dengue presents with the lymphocytosis. Lymphopenia is the presentation in the inflammatory response. So dengue, chikungunya, and hyperinflammatory response syndromes are the tricky situations in the post-COVID situations. And as I said, this post-inflammatory response, multi-systemic inflammatory response syndrome in adults is quite common. We have seen cases of this inflammatory response, and this has been discussed worldwide. The multi-systemic inflammatory response syndrome in the children is a well-known entity called as the Kawasaki syndrome. This also been, you need to have a rehabilitation plan be on the yeah. The post-COVID OPD, the initial assessment should be on the third week or 1 month, or when the RT-PCR is negative. It should consist of a thorough clinical examination backed up by HRCT, pulmonary function test because the COVID is a lung issue, 6-minute walk test because this will pick up the happy hypoxia even after 1 month or so, and the quality of life questionnaire. The assessment for associated multisystem complications is must, a cardiovascular examination, and you will not find any positive findings like congestive heart failure signs, but a plain simple tachycardia, arrhythmia may be the early signs of cardiovascular involvement. A plan for the second visit, depending upon the case presentation, should be 3 monthly or 6 monthly. But if you are suspecting that the COVID pneumonias are getting more worse than you are expecting, the early follow-up is mandatory. Second visit should be with PFT, 6-minute walk test, and again questionnaire. You may not do HRCT every time, but if necessary, yes. But after 3 months or 6 months, the HRCT is mandatory because this will tell us how the patient is going to progress in the years to come. The people who underwent the SARS and the MERS in 2003 and 2014, they have been followed for almost a period of 5 to 6 years, and almost everybody of them is showing a good improvement in the lung pathology. So, long-term approach and long-term examination, including HSCT, is mandatory for we people with COVID. A post-COVID OPD should have a rehabilitation area, and you need to have a good physiotherapy center for the lungs and muscles. This is unrecognized. We do not concentrate much on the physiotherapy, but that's the most important issue in post-COVID program: nutritional consultation and psychotherapy consultation. Beyond COVID treatment management, medicines, and whatnot, evidence-based consensus statement says that physiotherapy, along with the pharmacotherapy and a multidisciplinary approach, is the key treatment for your post-COVID people. And post-COVID rehabilitation is not that it will start after 1 month or so. It must start after the patient is there in the ICU or once he is shifted from ICU in the wards. It requires a spirometry. It requires a cappella or aerobic, because these are the simple tools which will make our lungs more and more um, the lung capacity will start improving with these simple measures. And nutritional assessment. We don't go for an extensive nutritional assessment. It's a plain, simple mini nutritional assessment program. Within minute, you can assess its nutritional assessment. And if this nutritional assessment score goes more than 12, you are happy that practically patient is not nutritionally deprived. But our nutritional assessment tool has said that almost everybody, patients who are being tested for this post-COVID program, they are below 12 and they require nutritional support. And you require proper diet plan. There are multiple diet plans which are there written, but you need a diet plan which is tailor-made. Each patient will have a different dietary pattern. Each patient will have a different dietary habits, maybe vegetarian, maybe non-vegetarian. So depending upon that dietary plan, you are supposed to have a tailor-made dietary plan so that you can give a good amount of protein, good amount of fibers, which is coupled with the nutritional support and the physiotherapy. They do recover very fast. So, as I said, this COVID has got an extended issues. It may extend up to 4 months to a year. People are likely to come with pulmonary fibrosis. People are likely to have a multiple organ dysfunctions. Even though they don't have a multi-organ dysfunction failures, they complain of fatigability because of multiple organ dysfunctions. But there is a good news. With the natural history today unclear for us, with the experience from the SARS and the MERS, which I said to you, and the current observations, we would hypothesize that majority of our patients will stabilize or improve over a period of long time. Very few are likely to progress to ILD, and this will be called as a post-COVID interstitial lung disease. So with that positive note, I think I'm going to conclude. Thank you very much.
Thank you, Dr. Ajit.
Thank you, Dr. Ajit. Really wonderful talk.
Many questions.
And there are many questions we can take up, but with the interest of time, already we have delayed and we have scheduled 45 minutes. I would like to go for a next talk. Dr. Ajit Kulkarni is a intensive care interventional pulmonologist. I will give his direct number. So if you have any queries, any questions, he can sort out personally. His mobile number is 922-5068-505. So you can note down again 922-5068-505. You can directly communicate with him. Am I audible?
Yes,
Hello?
sir, you are audible.
Onkar?
Yes, sir.
Okay. I will give a brief introduction about Dr.
Hello.
Immediately ready. I'm very much thankful to you, madam, for this CME. And outcome she has
Am I audible?
Yes, yes, ma'am, you are audible.
Sorry, I lost Dr. Amol there. We could not hear him. Um, I believe he was introducing me. Thank you very much for the invitation. And I would like to thank the IMA Kolhapur and Dr. Amol for giving me the invitation and the honor to speak to you all. Thank you very much for that. I'll share my screen now. Is my screen visible? Hello?
Yes.
visible.
Okay, thank you. So I am going to speak to you about enhanced recovery after surgery protocols. And this is one of the topics which I have worked on. I am an HPB anesthetist in Tata Memorial Hospital. I do not have any conflicts of interest to declare. The scope of my talk is going to be about what is enhanced recovery. I will briefly tell you what the guidelines are about. We'll share some evidence regarding enhanced recovery and post-operative outcomes. And lastly, I will tell you what we have done and what our experience has been about ERAS. So the concept of ERAS was, introduced by Henrik Kellett, a surgeon in the 1990s. And he used multimodal evidence-based perioperative elements or principles in open colonic resections. And he demonstrated that the hospital stay can be reduced by 2 to 3 days, which means a lot of money saved. And thereafter, this concept was adopted by various other surgical disciplines. And finally, an ERAS society was formed and was officially registered in Sweden in 2010. Now, what it is all about. So when there is a patient undergoes surgery, there is stress response mounted by the body, and which leads to pituitary and sympathetic nervous system activation. And what it creates is an insulin resistant state. What I mean by this is that the liver goes into hyperdrive to produce glucose. So there is increase in gluconeogenesis, lipolysis, and at the same time, so there is increased production. At the same time, there is reduced utilization. So the skeletal muscles reduce the uptake, the glycogen stores go down. As a consequence, there is hyperglycemia. And we know that hyperglycemia is associated with worse post-operative outcomes, such as increase in the incidence of infection, complications such as myocardial infarction, increased length of stay, and mortality. Now, another big stimulus for this insulin resistance is starvation. Conventionally or traditionally, we keep our patients fasted for many, many hours before surgery. And what it does is the fasting actually shifts the metabolism from anabolic to catabolic. And so this is one thing which, the enhanced recovery elements which are there in the perioperative period, the whole crux is to attenuate this stress response and reduce the insulin resistance. Now, so, and how severe can this insulin resistance be? Now that depends upon the magnitude of surgery. Okay, so laparoscopic surgery will have a lower insulin resistance compared to a major or a supramajor surgery. And it's not that it lasts only for the period of the surgery. The insulin resistance can stay from days to up to weeks after surgery. And it is independent of gender, age, or preoperative insulin sensitivity. It is not that it would happen only in diabetics, it would happen even in non-diabetics. And this is a typical recovery curve of a patient undergoing surgery. The red is enhanced recovery, whereas this blue color is the traditional care. Now, with traditional care, what happens is, with the when I say traditional care, I mean is, long duration of fasting. We don't, start enteral feed. We don't start feeding them after the surgery. We wait for bowel motility to return, and we don't get them to mobilize. They're bed bound for a very long time. As a consequence, what happens is their functional capacity decreases, and it takes weeks to recover to what they were. And sometimes they may, depending upon the surgical process and then the perioperative stress or storm that they have gone to, they may not even return to their baseline, what they were before the surgery. On the contrary, with enhanced recovery, because they're eating and drinking up until the surgery, we feed them earlier, we get them to mobilize soon after surgery. What has been demonstrated is that the functional capacity does go down after surgery, but they recover earlier than the conventional care. So the whole rationale for ERAS is to suppress the metabolic response to surgery, and the elements that are involved in the whole enhanced recovery pathway attenuates this stress response, and we support the organ function and reduce mortality, and thus hasten recovery. Now, what it requires is a multidisciplinary team. And the multidisciplinary team consists of obviously a surgeon, anesthetist, nurses, physiotherapists, intensivists, and nutritionists. But what is most important, and one of the most important stakeholder in this, is the patient himself, because the patient has to actively take part in their care. They have to be motivated preoperatively, that they have to be active after surgery. They are going to do the exercises before the surgery and even after surgery. And they are a very important stakeholder, because without patient cooperation, it will not make much difference. Now, this is a typical picture of all the elements in an enhanced recovery pathway, from pre-operative, intraoperative, and post-operative elements. And these are the things which are kind of systematically put together in a pathway and implemented, and your system processes improve once you kind of do all this, and it becomes a system process rather than, you know, a protocol. And so we will go through each of these in a minute. And in addition to this, now nutritional supplementation and pre-operative physiotherapy and prehabilitation has been added. Now, the whole theory of this is based on the theory of aggregation of marginal gains. So if you look at it, all these elements are very, very small things. They do not seem to, you know, what is, you know, starvation, how is that going to make a difference on patients' outcome after surgery? Well, yes, true. Each element has a very small impact. But when you package them together in a systematic way and as it's implemented, it has a strong synergistic impact. So let's look at the elements. Now, pre-operative, pre-admission counseling, not only about surgery, but, you know, conventionally we just discuss about surgery, but we should also be discussing, you know, getting the patient motivated, that they should be active during, you know, before the surgery and soon after the surgery. Fluids and carbohydrate loading. Carbohydrate loading is nothing but giving them carbohydrates or a sugary drink up to 2 hours before surgery. So a typical, conventionally, we would make them fast, you know, overnight and not give them water to drink in the morning. But here what we do is we tell them that they can have their dinner the evening before the surgery, and thereafter they have a sugary drink before they go to bed. We allow them water, no solids after midnight, but we allow them to drink water. And in the morning of the surgery, we tell them to have a sugary drink, such as a carbohydrate drink, and up to 2 hours before surgery. So this attenuates the catabolic stress and preserves the muscle mass, thus avoiding prolonged fasting and therefore decreasing the insulin resistance that I explained earlier. Selective bowel preparation. Now, bowel preparation causes a lot of dehydration. Patients have diarrhea episodes overnight. They feel dehydrated. There can be electrolyte derangement, even if we supplement them with IV fluids. So not all surgeries need bowel preparation. Even colorectal surgeries, it is recommended that only rectum or sigmoid surgeries would need bowel preparation. So selective bowel preparation makes the patients less dehydrated, less electrolyte derangement. Thromboprophylaxis, surgery we know is a procoagulant state. So we start them on thromboprophylaxis either before the surgery or soon after the surgery. And avoidance of pre-medication. This is again selectively given only in patients who are very anxious. Earlier, we used to give it to each and everybody, but this is, you know, in the context of daycare surgery, not for an inpatient surgery. And avoiding the pre-medication in a daycare surgery will help them recover faster and help them get home faster. Coming to the intraoperative variables, this is majorly done by the anesthetist, and some of the dots are surgically relevant variables, whereas the other ones are usually intraoperatively done by the anesthetist. So antibiotic prophylaxis should be given within 30 minutes before the incision to prevent surgical site infections. We use mid-thoracic epidural or regional anesthesia as an opioid sparing strategy. Opioid sparing helps in early recovery from anesthesia after surgery. We are also using short-acting anesthetic agents, which again expedite recovery. We maintain euvolemia so that by using either goal-directed therapy or avoiding over and under hydration in an effort to maintain tissue and organ perfusion. And we see to it that we maintain normothermia intraoperatively so that patients again recover from anesthesia much earlier. From a surgical point of view, the drains should be inserted if it is really needed. And this will help in mobility, early mobility of the patient. And minimally invasive surgery. This is a decision taken by surgeons to again decrease the post-operative pain, so less opioid medications or less medications for control of pain, and it also helps in mobilization. Can I request to mute yourself, everybody, because there is a disturbance that I hear. Thank you very much. For coming to the post-operative variables, here we use multimodal non-opioid analgesia. Non-opioid again to prevent the patient from being sedated or impaired mobilization as a result of that. So we try and use non-opioid analgesics to prevent ileus, and other post-operative complications. The other thing as anesthetist we do is post-operative nausea, vomiting, and prophylaxis, so that again they feel they are not dehydrated and they can mobilize and they can start their enteral nutrition early. For surgeons, the relevant part in the post-operative period is to avoid nasogastric tubes. And the nasogastric tubes are a big problem because first of all, it interferes with swallowing. It's a constant irritation at the back of the throat. It makes the lower esophageal sphincter incompetent, and there can be passive regurgitation and microaspiration leading to respiratory tract infections. Avoiding also improves patient satisfaction. The surgeons are also supposed to, remove their catheters and drains and other tubes as early as is safe from a surgical point of view, all in an effort to improve mobilization or hasten the mobilization. Post-operative feeding, conventionally what we do is, the typical orders would be, nil by our mouth for 6 hours after surgery. And whenever I ask the surgeons as to why this is, and they say, no, we have to recover from anesthesia. I said, we don't really need to, because all our anesthesia drugs are very short acting now. They're very clean with minimal side effects. So the patients, as soon as they are awake, they're, they're to eat, to drink soon after the surgery. We allow them to, we start with water. If they're okay, they have no vomiting, we give them clear liquids such as a drink such as Appy. And then if they are fine, then we start them on, liquids and then feeds. So early enteral nutrition, it helps in return of bowel function. It maintains intestinal integrity and reduces the post-operative complications. Similarly, early post-operative mobilization. Conventionally, we used to make the patients not move around, but here, as soon as it is safe, we ask the patient to mobilize in the bed first, then around the bed, and if they are fine, they can walk the length of the day. This may take 1 day at least to happen. But mobilization helps in prevention of venous thromboembolism. Physical activity improves the gut function and helps the patient recover faster. So these are the roles of, or the reasons for why these elements have been put in or built into the enhanced recovery pathway. Now, the IRAS Society was formed in 2010 formally, but they have been coming up with guidelines for various surgical procedures. And if you see, practically, it started off in colon, but practically it has been, done for, majority of the surgical procedures, from pancreas, gastric, gynae, bariatric surgery, liver resections, head and neck surgery, breast surgery. And now they have very recently come up with guidelines for esophagus, lung, cardiac, hip and knee replacement, cesarean section, and very, very recently, even in neonates for intestinal surgery, cytoreductive in HIPEC surgery. And they have also updated the guidelines for gynae, colorectal, and pancreatic surgery. So the IRAS concept has gained wide momentum across the globe, and it has been adopted by surgeons across various disciplines. And the only fact they have adopted this is because of improved outcomes. So let's look at what is the evidence for IRAS. Now, this is in pancreatic patients undergoing Whipple's surgery. This is a very elegant randomized control trial done by the Japanese group. and they compared ERAS versus standard care. It's a small randomized controlled trial. And what they looked at was patients in the ERAS group had, better functional GI recovery. So they opened their, they've passed flatus and feces earlier. They were started on nutrition early and early mobilization. So this was significantly better. They had less post-operative complications, 32% versus 56%, a shorter post-operative stay, and significantly lower readmission rate. Also a trend towards reduction in cost. Not only did they study the post-operative outcomes, what they also looked at the sarcopenia. And here what they did was they looked at CT scan before the surgery, and they did a CT scan again at day 21. And what they found was in the ERAS group, the muscle mass was preserved. Whereas in the control group, where all these things were not done, the muscle mass actually reduced. So this, what it tells us is that the whole process, or the systematic process that is into the ERAS pathway, preserves skeletal muscle mass. And they also looked at the quality of life. And patients, so the blue line is the ERAS group and the orange dotted line is the control group. And the patients in the ERAS group fared better on all the domains of QOR40 questionnaire. So what it says is that it improves post-operative surgical outcomes, it shortens stay, it preserves muscle mass, and it improves patients' quality of life. So from that point of view, ERAS is a very good thing. Another randomized controlled trial, this time in liver resection. And here it's a 160 patient study. Here what they observed was a significantly reduced complication rate, a shorter post-operative stay, 16 days versus 21 days, earlier functional GI recovery, patients mobilized earlier, there was significant reduction in cost. And what they also found was improved patient satisfaction. So the ERAS group patients were more satisfied compared to the control group. So if you look at it from the point of view of surgery, we seem to have a lot of benefits. And this is probably the reason why it has been adopted by a lot of surgical disciplines. Now, there are a lot of, if you see the literature, umpteen number of studies have been published in all the surgical procedures, colorectal, liver, gastrectomy. As I mentioned earlier, I showed you the list of guidelines. And now even in head and neck surgery, there are studies which are published. And if you look at or summarize, if I summarize all the studies in various procedures, what the common theme that comes across is reduced complications, earlier functional GI recovery, shorter stay, with no difference in readmission or mortality rate. Now I will share our experience at Tata Memorial Hospital. We implemented enhanced recovery program in our hospital since in 2014 February, and we did it across the GI surgery. And what we did was we implemented these variables. So preoperative optimization for comorbidities and also anemia, rehabilitation including nutrition, screening, and supplementation if needed, exercise and physiotherapy. What we asked them to do is, exercise is brisk walk, as brisk as they can for 30 to 45 minutes a day, 5 days a week, and to do pulmonary physiotherapy. Preoperative counseling about surgery, anesthesia, and ERAS pathway. Carbohydrate supplementation, this we did in the form of API, because when we started in 2014, there was no complex carbohydrate preparation in India. So we we found out API was the closest we could give. Yes, it's simple sugar, it's not complex carbohydrates. But there's no difference in terms of post-operative outcomes when you compare complex carbohydrate versus simple carbohydrates. And it's very cheap, and it's available, around around the corner. We gave DVT prophylaxis to our patients the night before the surgery. Selective bowel preparation was done only in selective cases, same with sedative pre-medication. For intraoperative, we did mid-thoracic epidural for our abdominal surgeries, which includes all the procedures. We used short-acting opioids if we needed intraop, antibiotic prophylaxis, antiemetic prophylaxis. We maintained intraoperative normothermia using a fluid warmer and a warming blanket. And in selective patients, we did goal-directed fluid therapy. For surgeons, it was left up to them to decide what incision, whether it was an open surgery or a laparoscopic surgery, and whether they should be putting the drains. In the post-operative period, we did multimodal opioid-sparing analgesia. We have an excellent acute pain service team who looks after our patients in the post-operative period. Early mobilization, the physiotherapist would see to it that the patients get mobilized. Early removal of drains and tubes and catheters was left at the discretion of the surgeons. Same with enteral feeding. We included all patients above the age of 18 undergoing elective GI surgery, ASA 1 to 3. We followed them up until 30 days of surgery after discharge, and we recorded their compliance with all the elements that I just said. And we looked at their post-operative outcomes. We graded the surgical complications using the Chlamydia classification. I will share with you the results across 3 surgical procedures, so Whipple's, liver resections, and gallbladder. We published our experience in pancreatic cancer resections in the Journal of Gastrointestinal Surgery very recently. So 394 patients over 3 years. And what we found, so what we did was we compared 2 different groups. We split the group in patients with more than 80% compliance with the enhanced recovery pathway versus those who had less than 80% compliance. And when we look at more than 80% compliance group, what we observed was a significant reduction in major complications, 28% versus 44%. We also found a significant reduction in mortality, 2% versus 6.8%. Our re-exploration rates were less. And we also had a significant reduction in post-operative length of stay, 11 days versus 15 days. And what we found when we looked at, how did we get these favorable outcomes? We looked at when we adjusted for confounders in the multivariate analysis, what we found was for the overall morbidity, age, and pancreatic fistula risk, a high pancreatic fistula risk score was an independent predictor for developing overall complications. Whereas in patients for major complications, age, high fistula risk score, and compliance with enhanced recovery pathway, if it was less than 80%, the chances of developing major complications was higher. Coming to our experience in liver resection, this is, we've submitted our data for publication. This is over a 5-year period. We had 433 patients undergoing liver resection, 59% of them undergoing major liver resections. And here again, the red bars are the less than 80% compliance group, and the blue bars are the more than 80% compliance group. And what we found here was that patients with more than 80% compliance had significantly reduced major complications. Also, they had a significantly shorter stay, 8 days versus 11 days compared to, and there was no difference in post-operative mortality between the groups. So here also we have a favorable impact of enhanced recovery program. Lastly, in gallbladder cancer resections, again, a 5-year data, we have submitted this manuscript as well. Over a 5-year period, 509 patients undergoing gallbladder resection, 42% of them underwent radical cholecystectomy, 13% underwent extrahepatic biliary tract excisions, and the rest of them were operated for incidental gallbladder cancer. And what we found here, again, a similar thing, that patients with more than 80% compliance had significantly lower overall morbidity and also major complications, with no difference in mortality, but a significant reduction in stay if they were compliant with the enhanced recovery pathway. So what it says is our data is very similar to what is published in the literature globally. So there are beneficial effects of ERAS, and everybody should adopt it. It may not be possible to implement everything together, but it can be done in small baby steps. Obviously, it was not a cakewalk. We encountered a lot of challenges. Like I said earlier, carbohydrate load, there was no suitable drink available. We figured Appy was the closest we could identify. And here I mean is non-aerated. It's not Appy Fizz. Appy Fizz, I do not recommend. We faced problem with our second cases, which were scheduled. It was very easy for the ward staff to be compliant with with this aspect of the protocol. But when the second cases happened, the fasting duration increased. So we faced problems. Thereafter, we empowered the nurses to administer Appy by discussing with the surgeons over the phone, is it safe to do so? And then the second cases would do that. And the nurses in the ward then administered Appy 2 hours before the second case. So around 1 or 2 p.m. induction. The other thing was educating people. We have a surgical training program. So registrars rotate every 3 months. So I used to take lectures for them. But despite all that, they come to us with preconceived beliefs from wherever they have been trained, and we have to reinforce periodically on a day-to-day basis, as in when we found they were non-compliant with certain elements, or if there was a violation for any protocol, we had one-on-one, we discussed with them. And we also got the physios involved in our rotation. They also had, so what we also faced another problem was communicating with everybody. It was a challenging task to, get to the surgeon, physios, anesthetists, nutritionists. So communication was a big challenge. Here we resorted to social media. So everybody has smartphones. We created a WhatsApp group, in-house WhatsApp group of surgeons, anesthetists, physiotherapists, nurses. So it was very easy to communicate and troubleshoot the problems. And we also educated them periodically on the WhatsApp group. So these were some of the challenges we faced and we encountered, and we circumvented in simple ways. Almost at the end of my talk. So before ERAS, our patients used to starve for a very, very long time. They used to be cold, weak physically, hungry. They didn't know what to expect in the post-operative period, mentally unprepared. They used to fear pain, and they were in pain and nausea. And post-ERAS, they are much more better prepared. They know what to expect after surgery. They are well hydrated, not thirsty. They're warm when they get up. They eat and drink, soon after surgery. No or very little nausea, pain-free or with minimal pain. And this is, I would like to share this experience. This is my patient. He was a second case of the day. We induced late around 2 or 3 o'clock, thinking it's going to be a simple case. But this was a pelvic mass, which was explored, and it became a difficult case. He had a massive blood loss, bled about 7 liters. We shifted him in recovery. And this is him reading a newspaper at 9:30 in the morning. So this just goes to say how the enhanced recovery pathway helps in improving patients or hastening patients' recovery. He was very active up until the day of surgery. He was very much into yoga and doing his yogasanas even before the surgery. So this was to illustrate that it does have benefits and positive effects. So in summary, it is not a one-person job. It is a teamwork. Yes, you require somebody to lead the project or the team and persevere and, keep driving the momentum so that, everybody stays together. It is associated with improved outcomes, post-operative outcomes, it preserves muscle mass, improves quality of life, and patient satisfaction. One question which I often get asked by the surgeons is, they'll ask me, Madam, if I do a bad surgery, how will ERAS improve outcome? Yes, if you do a bad surgery, it is not going to improve outcome, but what it does, it prepares the patient for dealing with the possible complications likely to occur. So they are better prepared to deal with the perioperative stress. And I always tell them it is an association, it is not a causation. Lastly, compliance with the pathway, as I said earlier, and I have shown you in the literature and in the study, in our own experience, has beneficial effects, and it improves outcomes and helps patients recover faster. Lastly, this is our entire ERAS team. The top row are our surgeons. Second row is our team of intensivists. Some of them are residents which have left us and gone, but still continue to work with us. These are our physiotherapists, my data entry operator, nurse, and our nutritionists. And I would like to thank all our surgery and anesthesia registrars who have been with us in the past, during their time spent in Tata Memorial Hospital. Thank you very much. If there are any questions, I would be happy to take. Hello. Can I stop share the slides? Dr. Amol?
Yes, yes, you can stop now. Stop, madam, yes.
Okay. So if there are any questions, I am happy to take any queries.
Hello. Thank you, ma'am, for such a beautiful.
I'm sorry, I cannot hear you. There was interruption in the audio.
Hello. Do you get me, madam?
Now I can hear you. I couldn't hear you earlier. I am sorry. I don't know whether it's the network. I don't know whether it's at my end, but I could get the chats.
Hello. Beautiful discourse. Hello.
Hello.
Hard.
I can't really.
Hello, madam.
Oh, Omkar, are you there?
Yes, madam. Yes, yes.
What is the problem?
मॅडम त्यांचा नेटचा काहीतरी प्रॉब्लेम आहे.
बरं, ठीक आहे.
हो.
त्यांना थँक्यू म्हणून आपण पुढे जाऊया. Our speaker is, she has Omkar,
Yes, madam.
are you getting me, Omkar?
Yes, madam.
Connect to Kolhapur, madam. Huh?
एक सेकंड.
You hear me? I can't hear anybody. Can anyone hear me?
I can hear you.
Oh, okay.
I don't know. I don't know. I cannot hear the person who was talking earlier.
Dr. Omkar, can we just take it from here if I'm audible? Can't hear anyone actually.
I had the same issue. I don't know whether it's the network there. Can you hear me?
I can hear you, Doctor.
Yes. So I don't know. I think the problem is the network there.
You're well connected, looks like.
Yes. So I don't know whether there was any question or anything. I have absolutely no clue. But I guess.
Be prepared to be lectured by me now.
Sure. At least you will have one audience.
I know. No, I think it's the network. Even I'm not very sure about my network because.
But I feel if I am in Mumbai and I can hear you and I can see you well, should be fine.
I sure hope so. I'm in Lavasa and this whole thing is rather shaky. And
Yeah.
mobile should be fine. Let someone else take over.
I don't know. We need to speak to Mr. Omkar.
see Dr. Patil or Dr. Shirke sir. हॅलो. अच्छा अच्छा, अरे नाही, काहीतरी गडबड चालली होती म्हणून मी तुम्हाला फोन केला. लेक्चर मध्ये गडबड होती म्हणून तुम्हाला केला. हॅलो डॉक्टर लोकापूर हिअर. काही प्रॉब्लेम आहे का? मला कोणाचं काही ऐकू नाही येते. हॅलो. मग लेक्चर सुरू करू का? कारण मला काहीच कळत नाही. ओके ओके, थँक यू व्हेरी मच. Hi, good morning, everybody. I have been informed right now that there is some network issue at the other person's side. So I'm asked to share my screen and start with the lecture. At the outset, I would like to thank KMA for Kolhapur Medical Association for inviting me for their web conference. I also thank Dr. Rajan Sancheti and DG Shield for involving me into this program. So my today's topic is what's new in pain. I hope I'm audible to most of the people. Yes?
Yes, ma'am, you are audible.
Thank you. Pain management now has become established in India. And as the earlier speaker, Dr. Agarwal, also insisted that even post-operatively, whenever you have taken care of pain, many of the further complications are taken care of. And because of that, the patient will be in a much more happier frame of mind. And also the other complications would be much less. Now, my lecture is precisely going to be about chronic and cancer pain and what all has been happening in pain. So the concepts are changing, and International Association for Study of Pain came up with a new definition. They just improved upon their older definition, which was from 1979. And under Dr. Srinivas Raja, right now they have come up with this definition, which says an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, this or resembling that has been added to this definition because pain is always a personal experience. We all have seen as anesthesiologists, as doctors, pain is the first symptom for which the patient will contact you. And it is influenced to a various degree by biological, psychological, and social factors. Now, pain and nociception are two different phenomena. Pain cannot be inferred solely from activity of sensory neurons, because you will find that a person who is suffering from the same disease or who was operated for the same type of surgery, they will have different pain scores if you are taking down the VAS scores. And the reason is because the emotional element might be slightly different in both the cases. So the life experiences also teach the individuals to learn and accept and deal with the pain. And hence, verbal description is only one of the means to express pain, and that's why this resembling has come into it, so that person who is unable to get across or verbally describe his pain also can be taken as suffering from pain, and we have to take care to alleviate that pain. The concept which has now come into it, because many of the doctors who are not practicing pain, my colleagues, they keep asking me about opioid crisis. But the thing is, in USA, people were relenting very heavily on opioids as post-operative analgesia for common disorders, even for chronic pain. And they thought that so long as the patient keeps complaining about pain, they have to do something about it. And hence more and more dosages of opioid were given. Sometimes they were completely irrational therapies for this. And that's why when they are talking about opioid crisis, it matters more to the West than to the East, where for us, we have been fighting for opioid management for our cancer patients and terminally intractable pain cases. And hence, not relying just on opioids, which are morphine is of course a gold standard, but we should go for multimodal analgesia. So there is something new in many directions. There are multiple variants, I would say, where newer things are coming in, and we will touch upon briefly on few of them. Newer biologics are coming in. You all must have heard about platelet-rich plasma injections. This platelet-rich plasma, or PRP as it is called, is a highly concentrated platelet and associated growth factor solution, which is derived from patient's own blood. So it is basically centrifugation process of autologous blood of the patient and separating the various components. The PRP and the Buffy they are taken. I mean, there are multiple types. I'm not going into the details. And even for us, this is a new field. So we are also not very sure how and what it is going to help. But basically, it contains some inflammatory cells and large amount of proteins, including multiple growth factors. The PDGF, transforming growth factors, vascular endothelial growth factor, epithelial factor, adhesion molecular like fibrin, fibronectin, and this entire cocktail, when it has been injected into an injured tissue, usually this is used for soft tissue injuries and musculoskeletal problems, it causes increased expression of anabolic genes and proteins, cell recruitment, proliferation, and angiogenesis, which might be implicated in tissue regeneration and healing. Now, leading to reduced tendon inflammation will automatically cause some amount of pain relief and improvement in the function. However, there have been multiple meta-analysis studies. This analysis itself has been criticized for not being encompassing, but they said that there is a low quality evidence from a subset that there will be a marginal short-term benefit in pain in PRT. However, in case of knee injections, it has shown a lot of positive effect on regeneration of the tissues and causing reduction in pain. Another new thing which has come into the pain management, which has tremendously improved our results, are the better imaging techniques. As you all know, that newer anesthesia machines, I mean, those who are anesthesiologists in this august audience, they would know that a lot of peripheral nerve blocks, even for the surgery, are possible accurately without almost minimal complications, is because of the USG guided probes, which are of higher frequencies. They are giving us better visualization, and that's why very precise drug delivery is possible, and that is improving our results very much. So many blocks are being tried right now, and of course that improves the recovery nevertheless, because the general anesthesia can be avoided, and in our case we can target the cells where we want to go. Many a times when we are doing Botox injections for muscular diseases, then they can be delivered very precisely to the muscle which is injured, instead of just going randomly giving the injections. So USG guidance has been a great boon without any radiation. Sometimes, however, I have found that in visceral malignancies, they could be silent. They're diagnosed at a very late stage. They are referred to a pain physician as, because many of the times people feel that pain management consultant should get involved only in the terminal stages, which is absolutely wrong. However, that is what the reality right now. When the patients are referred, many times they are unable to take any oral medication. So even though we have got oral morphine available, these patients may not be able to tolerate it. Nausea, vomiting because of the obstruction, subclinical it might be, that is not possible sometimes. So all these things like nociceptive and visceral both are seen in visceral malignancies, and that's where interventional techniques come into the picture. Now to do interventional techniques, especially the neurolytic blocks, earlier they went into disrepute because of lot of complications, and sometimes they used to be very scary, like paralysis, life-threatening emergencies, dissection of aorta, because you are working around the aorta. So CT guided sympathetic blocks are now being performed with great accuracy, and the complication rate has gone down drastically. The advantage of CT guidance is excellent visualization where you are going. You can plan your delivery much better. The ability to reconstruct the three-dimensional picture of the deeper tissues, especially in your superior hypogastric plexus block. They are extremely helpful in cancer patients where normal anatomy has been completely distorted. So even earlier, when we used to do it under CM guidance, we found that because of distortion of the anatomy, even though according to the bony skeleton, the block or the drug, you might feel you are in the correct place, the delivery could be horrendous. I mean, you could be giving into the tumor, you could be delivering alcohol into the vessels, the whole area is vascularized, and therefore CT comes to your help. As against USG guidance, the prone position allows sparing of needle penetration of the viscera, because usually when you are doing it under USG, you always have to go anteriorly, and that causes you, I mean, that makes you go through multiple tissues, which may prove to be fatal to the patient. As you can see over here, such advanced cases, I mean, even if you want to do an block, sometimes it is not possible. So doing a pilot CT also comes in handy so that unnecessary complications are avoided. Like I mentioned, there are multiple ways of performing. All the pain physicians we have been performing as per fluoroscopy. Because of good ultrasonography machines, now many blocks can be performed under USG guidance. The advantage of them being, of course, sparing of any radiation, they are easier to handle these machines. And the disadvantages would be the operator has to be very good. There is a huge learning curve, which the person has to know all the structures and how the USG is looking. Retroperitoneal organs are not seen, especially in these patients where the anatomy is totally distorted, and perforation of the structures, which is always there. So in a CT scan, there is a risk of radiation exposure. We'll see shortly how we can minimize that. And there is no real-time guidance because you introduce your needle, go out, again take a one cycle, come in and adjust the needle. Therefore, we always suggest that whenever you are doing any CT-guided procedure, now we are getting probes which are basically marked. So the distance and everything can be marked, and accordingly, you don't need to take multiple cycles. MR imaging, of course, is not available for us for the procedures, and endoscopic ultrasound guidance, none of the pain physicians are doing right now. Contraindications for any blocks will remain the same. They have not really changed. However, because we have got better CT guidance, many of the cases which were earlier deemed to be non-operable or where we could not do procedures earlier, we can definitely do them now. This is how we plan the CT whenever we are doing a procedure. Like you first decide the region where you are going for, say, celiac plexus block. Like here we are going for superior hypogastric plexus block. So you take multiple slices, you decide which slice is the best for you. You do the entry point marking. This is how we do the entry point marking, because anteriorly there are no bony landmarks. So you have to keep multiple needles, choose your section, and then accordingly you can go inside. And this is how we plan our sections. This helps us tremendously because earlier paraplegia was a dreaded complication of neurolytic blocks. The artery of Adam Kivis has a variable origin, but mostly arises on the left-hand side at the level of 9 to 12th intercostal artery. And if you remember, for celiac plexus block, your entry point is between D12 to L2. So if you're doing it under fluoroscopy, then you're likely to miss these structures. And this can have tremendous fallout for you. Now, to avoid pneumothorax, it's also very helpful because you can see this like on both the sides, the lung is very much down there because sometimes patients will take deep breaths, the anatomy is distorted. So the CT will always help you for doing any of these things. Again, we are seeing something like the ganglion impar block, where you can actually see how the drug is spreading. And therefore, you are much safer doing it under CT because you don't have to go through the disc causing further discitis or any of the problems. And you can do a beautiful block, and it is extremely satisfying, one of the best blocks for any perianal malignancies. Lumbar sympathectomy is a bread and butter for most of the pain physicians because in our society, in our patient population, there are multiple cases of peripheral vascular diseases, either related to the age or to taking nicotine or any other substances. And therefore, doing them under CT guidance gives you beautiful pictures. You can see this 3D construction, and here only with a single needle you can be sure that you are reaching the plexus, which is located at L2 lower border, L3 and L4 upper border. So in single needle technique, causing least trauma to the patient, you are injecting your alcoholic solution. Your dosage remains very low because the delivery is targeted and precise. As you can see, it is at the anterolateral part of the vertebra, and that's where your plexus is located. So these people get excellent, not just pain relief, but the healing of the non-healing ulcer is far superior. Then we come to the CT guidance for celiac plexus block, like I mentioned, and even like you can see in this advanced malignancy, you can still give a retrocrural block. This is my dye. We always put a dye because the drug will not be radio opaque, and you want to know where your medicine is going to travel. Here also in this advanced malignancy where the patient also had ascites, we could still give the block and patient had excellent pain relief. So these are some of the cases which are highly satisfactory to both the consultant as well as to the patient. And this is with a single needle technique. So trauma to the patient is the least. Now we move from newer guidance techniques to newer technologies. In some of the patients, regardless of whatever blocks you have done, oral morphine you have given, the requirement is very high. And therefore, the implant of morphine pumps is advocated. Earlier, we used to have problems because these implants came with a battery life. And so it was routine practice to give them or advise them at the end of the life spectrum. However, at that time, patients' general condition could also have deteriorated very drastically. So in some cases, like osteosarcoma, or where in prostatic cancer, breast cancer, where if the spread has started going to multiple skeletal metastasis, then in that case, implanting with a pump will be much more kinder to the patient. Here is one case where we had a malignant nerve sheath tumor in a 51-year-old male patient, and whatever amount of pain medication we gave him, including morphine, NSAIDs, it was not helping the patient at all. In this patient, we decided to implant the morphine pump. And once we had implanted the morphine pump, which is completely inside the body, then we could add even local anesthetics to the whole cocktail, and that gave some relief to this patient. So there are some cases like this. Now, there are newer pumps, like I said, like Tricumet, where the battery is very long lasting, and because of that, you don't need to change them very often. Another application of that would be in spastics. For spastics also, we have done them in the past, and the lasting battery really comes in handy for all these children or even in adults, where you can give them baclofen intrathecally. This is how the pump looks under X-ray, and this is where you can inject your, whenever the drug is finished, you can replenish it with this, and you can keep checking that the pump is working and connections are fine. Then you could have newer technologies like cooled RF. Now, radio frequency ablation is what we had always been doing. So if you see the standard RF ablation components, there is an active electrode, there is a dispersive electrode like our grounding pad of the cautery, and then there is a radio frequency generator machine. Patient completes the circuit and creates the lesion. Usually what used to happen with our conventional radio frequency was there was an ionic heating, because ions in the surrounding tissue, they move creating friction. And that's why they heat up this probe, which is the exposed tip of this probe. The entire probe will be insulated and only the tip. This decides how big a lesion is going to be. So for trigeminal neuralgia, you would not use more than 2 to 5 centimeter exposure of the tip. Whereas in, say, lumbar facet joint, you require 15 millimeter of probe. So these are decided by the target organ. Now what happened was, like when you were using thermal probes, like for your ganglion lesions, like trigeminal ganglion, you have to use the conventional traditional one. You don't want a bigger lesion at all. However, what we thought was that this has to be a very specialized technique, because you have to be parallel to the nerve. If you are perpendicular to the nerve is not going to get burned, because the lesion is going to be behind the where your target is. So they came up with this water cooled probe, which has got a moving line of fluid inside it, and therefore you can create a huge lesion around it by giving RF energy to it. So instead of our elongated lesion around the probe, you are going to get a huge peripheral region. It doesn't matter if you are perpendicular or parallel or even nearby, the nerve will definitely get caught. So it has got a larger area of capture. So where does it help us? This helps us in bigger joints where the location of their nerve supply is not always very predictable. So in sacroiliitis, in sacroiliac joint arthritis, we can use this. In hip joint, again, we are using it at designated points. In lumbar facetal arthropathy, we are using again cooled RF technology. And nowadays, as a what should I say, as a stopgap arrangement for these people who have got bad osteoarthritis, very painful knees, just before going for the surgery, we can offer them in the first or second grade of osteoarthritis, we can offer them this radiofrequency of geniculate nerves, which will give them relief so that they can continue to be mobile for a longer time. So we have seen what all new things have been happening. So it is not just newer advances, but many times there are newer applications of the drugs which are already known to us. Sometimes there are newer ways of managing a patient. And all this comes together when a pain physician looks at a patient. Now, I had this 50-year-old lady who had come with CA esophagus. She was complaining of severe pain in upper abdomen, could not tolerate morphine, had severe nausea and vomiting. High doses of non-steroidal anti-inflammatory drugs were given. Tramadol was tried, but she was not getting relief either. So we decided that she requires a multimodal analgesia. So celiac plexus block was offered to this patient, which gave excellent pain relief. So the reason is everything might be there, but you have to understand that every patient is an individual patient and the treatment has to be tailor-made for this patient.
दुखतंय कितपत तुम्हाला?
दुखत काय नाही, जर समजा काही वातुळ खाण्यात आलं तर त्रास होतो.
नाही तर अजिबात पोटात दुखत नाही.
बाकीचा काय नाही त्रास होत.
पोटात दुखत नाहीये. शौचाला व्यवस्थित होतीये.
So you can see that this patient had such an advanced disease. She had ascites. However, her pain levels had gone down, so the life was more bearable for her. Another patient to present you is a 58-year-old male patient. He is a known case of operated CA buccal mucosa with apical lung, rib, and liver mets. He received radiation to the apical lung mets, and the pain, actually the pain at the local site and part of the pain went down, but he suddenly started having very severe pain on the inside of the arm and the upper back. Now, multiple people were doing multiple things. They even showed him to an orthopedic person. Then his cervical neck MRI was also done. As usual, after the age of 50, you will find some disc over there. So he had C6 discs showing. So they even gave epidural steroid injection for him with no pain relief at all. Then if he started going from people to people, multiple doctors, pain physicians also were involved, some oncologists were involved, and patient got on to fentanyl patches of 50 microgram per hour, 2 patches, buprenorphine patch, 10 each of 2 patches, and on top of it, he was admitted in Ruby. He was completely incoherent, but still in pain. He started getting IV paracetamol on top of all these patches at 1 gram TDS, plus injection tramadol 50 milligram, and people even tried giving him morphine tablets. Now with all this, of course, and in between I forgot to tell, somebody tried to give him a nerve block also of intercostal nerve. I don't know, because at T1, it is very difficult to find a nerve, and a nerve block really cannot be done. You have to do epidural is the way to go anyway. So actually, when I saw this patient, what I realized was that what he had was opioid-induced hyperalgesia. Now, this is a condition a pain physician will know, and unless you know it, you will not be able to diagnose it. So this is defined as a state of nociceptive sensitization, which is caused by exposure to opioids. So there is a paradoxical response. Whenever the patient is getting opioids, he will complain of pain. He gets more opioids and he complains of more pain. Now there are many mechanisms like the central glutaminergic system, spinal dynorphins, descending facilitation, genetic mechanisms, decreased uptake and enhanced nociceptive responses. And there are also NMDA receptors involved into this. So basically, we have to differentiate between clinically worsening pain because of the disease advancing, development of tolerance, but development of tolerance will be only 10%. And when you adjust the dosages, patient is happy. Now here, increasing the dose caused more pain complaints. So there is something definitely wrong. OIH is the diagnosis in this patient. So basically, you have to think about detoxification, gradually reducing the opioid doses, causing opioid rotation. You can use other opioids instead of the ones which are giving the problem, and use of certain specific NMDA receptor antagonists. In this case, we gave him multiple drips of ketamine, which is an NMDA receptor antagonist, and that gave a lot of relief to the patient by slowly decreasing him, from weaning him away from such a high dose of opioids. Actually, he was referred to me for morphine plump implant, but now we find, in his own words, this is how the lesion was. So if you try to give any kind of nerve block, it is not going to help because his entire nerve is stuck somewhere there. And if you try to give anything, the lungs are always there. So you really cannot do intercostal nerve block there.
मी सुनील दत्तात्रय चव्हाण कॅन्सरग्रस्त आहे. माझ्यामध्ये पुण्यावरती हॉस्पिटलमध्ये ट्रीटमेंट चालू होती. तर माझा डावा हात खूप 1 वर्षापासून दुखत आहे. तरी मला अल्ट्राशिल गोळ्या, ऑल्फिन लेवल गोळ्या आणि फॅश 2-3 प्रकारचे फॅश लावले होते. तरी माझा हात बरा होत नव्हता. ओव्हरडोस झाला तरी माझं दुखायचं थांबलं नाहीये. तरी मी पुण्यातील कोल्हापूर मॅडमकडं ट्रीटमेंट चालू केलं. त्यांनी चांगल्या प्रकारे अभ्यास करून माझ्या हाताचा उपचार केलेला आहे. सगळे डोस क्लिअर करून मला आता चांगल्या प्रकारे बरं वाटतंय. धन्यवाद.
So basically what you need to do is to find out the reason, adjust the medication. So the new thing is there are no rules. The new thing is the patient's treatment has to be tailor-made. There is another case which is very interesting and something very close to my heart. I had this 90-year-old male doctor patient, very dear to all of us. He was complaining of severe back pain. Naturally, at the age of 90, you expect a lot of degenerated joints on the spine. There is sarcopenia, so muscle mass is much less. There was basically pain in the low back with radiation over both the legs, back of the thighs. Sitting was very painful. Getting up was painful. He was given a lot of NSAIDs. He was put on tramadols, like combination drugs of tramadol with paracetamol. So it caused a lot of drowsiness and clouding of judgment, which was the worst thing to happen to him. He didn't want that. He was active right even in that ripe old age. And somebody had given him epidural steroid injection with no relief, because they could see, like I said, like if you take out somebody's MRI over the age of 50, now here the patient was 90. So if you do that, you're bound to find some kind of a disc or something going on. But maybe that is not an answer to the question. A lot of physiotherapy was given. People insisted that he should do this, he should do that, but actually it started compounding his pain. And then finally we decided to give him radio frequency ablation of the facet and SI joint, and he got excellent pain relief. I mean, of course, he was extremely realistic. He knew that some amount of pain was going to be there, but so long as he was mobile, he didn't mind that. I'm sure you would recognize this grand old doctor, Dr. KB Grant, and he was very kind enough to allow me to interview him after the procedure was done.
This backache of mine is day by day, I think, getting less and less. And the very funny thing that I want to tell you, that if I sit on a chair like this, I will get up. The backache is very little. I start walking. Why?
So here what I would like everybody to understand is that the newer concept is that it is not that somebody is complaining of pain and you have to give them some medicine, you have to do some operative procedure, you have to do some kind of a nerve block. It is not correct. The new concept now is that of total pain. And here there are 4 different modules: physical, psychological, spiritual, and social. Especially in my cancer setting, I find that if we concentrate on all 4, then the results are phenomenal. So you have to understand what exactly is happening with the patient, not just to the disease, but patient as a whole. And that definitely gives us excellent results. Practicing in pain management since 2002, that is almost 18 years now, what I've realized is that, like Epictetus said, happiness and freedom begin with a clear understanding of one principle: some things are within your control and some things are not. Chronic pain for me has been just like that. Thank you very much. Thank you to Kolhapur IMA, Dr. Amol Kodolikar, Dr. Shirke, and their team for inviting me here. Thanks very much.
Thank you, madam, for a very excellent presentation. And so nice to see. Bring smiles. Sorry, I had some technical difficulty. And I think Dr. Amol is there. I thank Dr. Shirke also and their team of Kolhapur IMA. It was excellent to hear from you about the pain. Thank you. Can you take your please, Dr. Amol? Amol sir, I think Dr. Shirke.
Yeah. Thank you very much for this beautiful discourse. Now we will go on to our next speaker. One speaker. Next speaker. 1 minute, sir. Vinay Patki, sir.
Can I take on? Dr. Patki, sir.
Yeah, sir, you take over, sir. Patki, sir. Vinay Patki, sir.
Vinay Patki. Okay.
Dr. Patki, sir.
Yes. Good morning, everybody. Am I audible?
Yeah.
Introduction
Afterwards, I didn't.
Just a second.
He's given it.
Just a second. Yeah.
Dr. Vinayak Patki, sir.
So to
Please go
introduce.
ahead.
Yes.
Welcome,
Can
sir.
I take over?
Yeah, yes,
Yes,
sir.
yes.
Take over, sir. Yes, sir. Take over.
Yes. So I
Dr.
shall I
Vinay
start?
Patki. Sir, I'd like to introduce you first. Will it be
Yes, sir.
okay?
Yes. Yes, yes,
Need
please.
DNB from UK. Sir is Chief Consultant, Pediatric Intensivist and Head Advanced Pediatric Critical Care, Department of Pediatric Neonatology from Wanless Hospital, Mirrors. He's a Program Director, Pediatric Intensivist, Fellowship Program from Wanless Hospital, Mirrors, Managing Editor, Journal of Pediatric Critical Care, Executive Board Member, Intensive Care Chapter of Indian Academy of Pediatrics, National Convener, Essential Intensive Care, National Convener for IAP TIPS Program, Training in Pediatric Emergency by Simulation, National Faculty Basic and Advanced Pediatric Intensive Care Courses in India, National Faculty Simulation Program related to neonatal, neosim and pediatric intensive care, PG teacher also, and sir is Chief Consultant, as I said. International conferences. So also he has honors from Fellowship of Royal College of Child Health and Pediatrics, London, UK, Fellowship of Indian College of Critical Care Medicine, FICCM, Fellowship of American College of Critical Care, FCCM, and valuable contribution to the field of critical care research development of national program. Best Oral Scientific Paper Award in National Conference of Pediatric Intensive Care. Best, a lot of awards he has received. Invited as a national faculty for simulation based training in neonatal and pediatric emergencies. Sir has received a lot of awards and has a immense devotion towards service and community. So I extend participation in Pulse Polio program in 2000. Health advices to parent professional executive training. Free. I request him to take over. Thank you, sir. Please continue.
Okay. Thank you very much, sir, for your kind introduction. At the outset, I would like. Am I audible? Am I audible?
Yes, yes, audible.
Yes. First, I would like to, at the outset, like to thank Kolhapur Medical Association office bearers and especially Dr. Amol Kodalkar for giving me this opportunity to talk on a different subject today. And so I'm going to talk on snoring in children. Is it a red flag? So I represent Wanless Hospital, was one of the oldest institute in this country. Almost 125 years of healing and hope we are doing. And today's talk is on snoring. So all of us, we know sleep is a vital for child development because a lot of child growth occurs in the sleep because of growth hormone, mainly secretes in the sleep. And it is no surprise that many parents worry if they hear a child there's snoring. So snoring is a condition that occurs when partially nose or mouth is partially obstructed while sleeping and create a audible sound. So this how the snoring occurs. If we hear for 2-3 we get irritated. Just imagine what can be happening to the parents, what can be happening to the child who are constantly get snored and get disturbed, not only for themselves, but the family also. So snoring in child is often a little concern, especially if it is happening occasionally. But if it occurs frequently and snoringly, definitely may signal a problem of disturbed breathing during sleep. So most of the times we take snoring quite lightly. So it will disappear on its own. It will take some time. We'll wait. But when it becomes frequent and severe, then it's take its own turn, and things is quite goes silently and create a lot of issues to the child. So important question is all snoring in child is the same? So on a right side, left side, you find a primary snoring, that is called, which we can call as simple or habitual snoring, where there is no other associated noticeable symptoms or diseases are there. On the other side, red part is shown as obstructive sleep apnea. Is the most fragmented sleep, negative impact on physical and mental health, learning and behavior. And this whole concept, whole syndrome is called as obstructive sleep disordered breathing. So this is a quite common confusing terminologies are there. As the science evolved, the terminologies evolved, we got different terminologies and its own importance, and that's why it is a quite confusing. So let's, before to remove the confusion, what we have to deal with the definitions. How we are going to deal obstructive sleep disorder breathing. This is actually syndrome of upper airway obstruction during sleep, characterized by snoring and or other associated respiratory efforts. These are the very important. So this is a big group of syndromic variety, and different entities are there. What is called as primary snoring, I actually told you, that is habitual snoring less than 3 nights per week without apneas and other associated things are there. We can call it upper airway resistance syndrome, where there is snoring, increased work of breathing, frequent arousal, but obviously there is no recognizable obstructive events are there. Then what we will call as obstructive hypoventilation, where end tidal EtCO2 is raised with snoring, but there is no obstructive events are there. And then it's a serious part of what we will call as OSA. It is called as recurrent events of partial and complete upper airway obstruction with hypopneas, apneas, and all these things. So question is, how common is the snoring in children? So occasional snoring is believed to occur in almost 27% of the children. Primary snoring without other symptoms occurs in 10 to 12% of the children. So 1 to 2 or 5 to 5.7% of the children have obstructive sleep apneas, and 70% of the children diagnosed to have sleep disorder breathing have a primary snoring. So this is a bit statistics of snoring. So it is not an uncommon entity, though OSA has associated, this is a very less percentage of the people get obstructive sleep apnea. Important is what are the causes of snoring in children? Why child snore? The most important cause of snoring is the large or swollen adenoids and tonsils. This is the most common cause. Then comes the obesity. Because of modernization, fast food, junk foods, we are landing towards obesity. And what we are getting, obese children more likely to have snoring. Then nasal congestion, allergic, most flu-like seasons, in the season, rainy season, cold season, we get nasal congestion, and what we get is snoring. Then we have allergies, different allergies mainly due to dust, asthmas. Then sometimes you can have anatomic characteristic faces like deviated nasal septum, retrogranthia, etc. Then we have different neuromuscular disorder. These are and nowadays what we are getting is environmental tobacco smoke and contaminated air is responsible mainly for snoring in children. And recently a study come as short duration of breastfeeding is also associated with snoring. So is the snoring is dangerous? Yes, definitely snoring is dangerous when it comes to obstructive sleep apnea, which can seriously affect the child's quality of life. And this is why important is a American Journal of Respiratory and Critical Care Medicine 2017 has related snoring inadvertently, negatively with quality of life. That's why it is important, not only serious side effects, but quality of life. So how snoring is in the child is dangerous. So what can happen? Child can have sleep apnea. Child can get fatigue because of not getting proper sleep, get fatigue. Child can get different nightmares, and child just gets up frequently. There are fragmented sleep patterns are there. And because of this, impaired recovery from the illnesses. All this causes physical and mental health, not well-being, related to impaired recovery from different illnesses. They frequently fall sick. Then physical and mental developmental disorder. This is a very hidden area where we cannot, unless and until we ask proper history about sleep and snoring, we cannot able to sometimes pick up this point. If it goes to a serious turn, serious level like OSA, we can get cardiovascular abnormalities like pulmonary hypertension, right-sided right ventricular diastolic dysfunction, hindrance of organ growth, organ health. So snoring at different stages at severe level affects overall physical and mental well-being of a child. So these are some videos how if the child snores and doesn't get a proper sleep in the night, how his performance gets affected at different areas. So this child in the school cannot able to concentrate, sleeping, in fact, it is falling. Some children get this, they cannot able to take foods properly, their daily routines properly, their play gets affected, and they get what is called as a poor quality of life. So this concept of snoring related to poor quality life is increasing, and you can get so many this kind of videos and pictures and clinical cases. And unless and until you ask proper history, you may not able to get the diagnosis of snoring. So how it affects? It affects almost every part of our body. Neuromuscular, you get fatigue, depression, attention deficit hyperactivity. You can have occupational accidents and motor vehicle crashes. Cardiovascular, a lot of congestive cardiac failure, coronary diseases, systemic and pulmonary hypertension, metabolic syndromes are also associated. This is all related to. So if you can see, it affects in each and every part of body related to GRD, neuromuscular fatty liver disease, surgical implication because of obesity. Overall morbidity and mortality gets increased. So this we talked about the severe form of snoring called as OSA. Now the question is whether primary snoring is also dangerous. So infrequent snoring is not usually dangerous. So past evidences from before 2012 or 14, they were considering that primary snoring did not rise to any level of OSA. But if you have seen the incidence now, 5 to 7% of OSA children have primary snoring. And recent research shows that cognitive impairment and behavioral problem of more in children are with primary snoring than those without. So this is data from 2014. And latest data from 2019 from Frontier in Neurosciences suggests that there is a definitive negative impact on CVS and CNS related to primary snoring also. So that's why we have to treat the primary snoring, or you have to keep track on the primary snoring because it can turn also be dangerous. Snoring in children and the family. You can see this kind of picture, other siblings or sometimes parents who are sharing the same room with the snoring child can have a fragmented sleep, and they can get a neurological or psychiatric problems related to disturbed sleep and disturbed cognitive functions because of this snoring child. Then what are the signs that snoring in child could be a sign of bigger concern? That means if any of those, what can be the pointers where we can consider it as an underlying serious disorder is happening with this kind of children. So you have to ask the parents about how many times the child snores, or whether the child snores continuously. Continuously is a very alarming signal. And even if the child has more than 3 nights snoring attacks, 3 nights per week, that means 3 nights in a week or more is a serious issue. Then suddenly gasping or choking and getting difficulty in breathing while sleeping is also an alarming signal. If the child is getting bedwetting every day, that means called as a primary nocturnal aneurysm or secondary nocturnal aneurysm. So any child more than 3 years of age, if it comes to in bedwetting, you have to ask history of proper, whether he gets proper sleep or not, and whether he is associated with snoring. Then morning, any child coming to with morning headaches, morning heaviness of head, then daytime sleep. This is a usual complaint from the parents or in the school. If the child always sleeps and they contribute to the mobile watching or TV watching, but it is not a concern. It can be a snoring issue also. Then difficulty in concentrating on learning. If child performance in the school is deteriorating, child is not able to cope up with the kids who previously used to be, then it is an important issue that it is an alarming signal. Then very important thing in an adolescent age group or pre-adolescent age group is a hyperactivity. The child, if you parents are complaining the child is becoming suddenly hyperactive, is not attentive, is cranky, is fighting always with the parents in the school, if they are not attentive, is not his self-destructing or other destructing issues are there, definitely this is the issue. And either landing towards obesity because of frequent eating, or if it is not able to gain weight, as is called as failure to thrive. These are indications of snoring, that means the serious concern. So when parents should consult a pediatrician, this is important aspect of general practitioners also. If most of the time they come to you as general practitioners, or when they should consult a pediatrician. So pediatrician play a very pivotal role in as far as snoring child is concerned. So if the child wakes up tired, so sleep should be a freshening for each and every one of us. If you are not feeling fresh in the morning, that means your sleep is not proper. Issues may be related to snoring. Then as child is not getting up early, this is usual complaints from the mothers or parents ki my child doesn't wake up early. Then has very low energy level throughout the day. Then he is scared to go to sleep because he gets choked. He's not ready to go to sleep and he tries to prolong the sleep induction or sleep as he's scared of going to sleep. Then as I already discussed about wetting the bed, then cannot perform the course like before. Child has become very less attentive, has eye bags despite sufficient sleep, and rapid mood swings. This rapid mood swing is a what is a hidden symptom of snoring and snoring related sleep obstructed sleep disorder. Can clinical examination points towards etiology? Yes. So we have to do a clinical examination thoroughly. As a pediatrician, we always check through head to foot examination. We get a lot of clues. So if it adenoid or tonsil is the issue, what we get is a chronic mouth breather profile. So this is a flattened nose, shorter upper lip, receding chin, what you are seeing in this photograph, and forwarded head posture to accommodate that obstruction from adenoids. So this is called as classical adenoid faces, and just keep untreated, they are likely to have different chronic sinusitis, different growth pattern. And even if you don't treat this early, you can lead to a chronic adenoid faces. Then allergic rhinitis is strongly associated with snoring. So these are allergic cobblestones are there just below the eyes. Then child is constantly rubbing the nose, called as allergic salute. Then there are allergic shiners below the eyes and mouth breathing, and that again we call what we call as a adenoid or mouth breather face. Then there are specific syndromes where because of related to the obesity associated or related to the maxillary structure, maxillary growth and overall structure of a face, they land in snoring. One of this thing is Prader-Willi syndrome. These are the quite obese children associated with short hands, stubby nose, thin upper downward mouth, and they are overweight, and this combined picture leads to snoring. Down syndrome, all of us we know, we must have gone through as a pediatrician, is a common entity, but for a general practitioner also is a happy-go-lucky children. They are obese, there are a lot of other issues, and because of the trisomy, extra chromosome, they are born or they are more prone to get snoring. Then there are different entities, what we call as mandibular hypoplasias. So different syndromes are there. Some of them, they live for long, like Cousins, Stritcher-Collins syndrome, Pierre-Rodin syndrome. There are a lot of characteristic phases are there, where the mandible is quite hypoplastic and it is obstructing, when especially when they sleep in a supine position. Then neuromuscular disorder, here the problem is not, here the problem with the hypotonia of your oropharynx and pharyngeal nasopharynx and wall, where because of hypotonia, it is obstructing your airway, like spinomuscular atrophy, some congenital myopathies, congenital neuropathies, some muscular dystrophies, and sometimes myasthenia also can, juvenile myasthenia gravis also can present like this. Another important cause is large tongue, can be a syndromic variety because of Beckwith-Wiedemann syndrome, can occur in mucopolysaccharidosis, can occur with untreated or neglected hypothyroidism. So large tongue can be a bothersome issue and can be contributed to the snoring. Then very important thing, you have to ask the child, open the mouth and see the tonsillar enlargement, how the tonsils are enlarged, and they are graded in from grade 0 to grade 4. So from grade 1 it is less than 20%, grade 2 25 to 5%, and above 75% in grade 3, and if it are obstructed. So this you can get indirect assessment, but remember these are, you are doing the assessment during a child is awake. Once the child is sleepy, they even grade 2 or grade 1 can create more issues. So not necessary should be only focus on grade 3 and grade 4. Now we know this child is likely to have, now we have to investigate the child. There are some investigations which can point us towards etiology and complications, and other is the actual status of snoring child. So recognition of morbidity, very important thing, you should always check a blood pressure of these children. So these are likely to develop hypertension. Then all growth parameters has to be taken, either they are failure to thrive or you have obesity. Two extremes can be there. CBC you can get leukocytosis, raised DSR because of allergies, then the absolute eosinophil count, few pointers towards underlying allergic disorders. Then CRP, this is again a very important parameter. It suggests underlying infection like maybe chronic adenotonsillitis, chronic sinusitis. So these are our underlying issues, sometimes otitis, that can lead to persistent CRP. Blood sugar level can give on lipid profile, especially in OB children, because as a part workup of obesity also you have to do. Thyroid profile, only sometimes not clinical hypothyroidism, but subclinical hypothyroidism. As a part of workup, you can pick up from as a snoring child. Then APG and EtCO2, these are the blood gases. We have to find out partial pressure of oxygen, end-tidal CO2. End-tidal CO2 is not possible, but you have to, if a tabletop side portal EtCO2 machines are available, where in the OPD also you can able to check their EtCO2s. And if they are around 40 and above during sleep, there is a pointers towards serious disorder. Allergics, different allergic skin test if required, and if you are sure that this is contributing to the allergic. And last but not least, very important is 2D echocardiography. Especially this is advice for my whole people who are working in ENT and other where you have to do a pre-operative. Most of the times adenotonsillectomy is very easy and considered to be a very routine procedure. But if you are not taken care of the cardiac issues previously, if you don't rule out pulmonary hypertension, you can land in a post-operative complications. Then objective evidence of snoring and adenoids. So lateral neck X-ray is a important thing, as here the markers pointers is showing that it is obstructing the rhinopharynx, and if you see here, the airway is quite obstructed here. This is a very narrow airway here. So these are the adenoids here. You can see soft palate, palatine tonsil. So you should know how the structures look on lateral X-ray. Then flexible endoscopy is a true picture or three-dimensional picture or real-time picture of you have to do nasopharyngoscopy as well as you have to do a video laryngoscopy. So just I'm going through now I'm the person is going to the, this is a medial turbinate, he is advancing the, this is a nasopharyngoscope from nose, he is going inside the nasal cavity and nasopharynx. So he is advancing the probe, he has gone now. This is a septum, this is a posterior part of septum, aqua, and this is posterior part of septum, which the presenter is showing. Here we are getting what we get is the adenoid area. So this area has to be focused because enlargement of tonsil in a profound way you can able to pick up at this particular area. Then when we advance go, then we have to find out the again this is a adenoid area where the present then this is eustachian tubes you have to find out, because blocked eustachian tube can lead to chronic otitis media, and this can lead to problem. This is other side of eustachian tube. Then this is going again advancing the scope further, where we are going towards the nasopharynx now. And here this is a, so this is a part of soft palate. You can see the glottis now here. So a lot of these areas has to take care of, and this is uvula is pointing, and then again you have to point and see this is a posterior part of some. So where the soft tissue getting obstructed, flexibility, early hypotonia, all these things you have to, you can get these things. Then about video laryngoscopy, this is again very important, palatopharyngeal reflex. You can rule out other areas of arytenoid fold, true cord, false cord, so many things, information you can get real time from flexible endoscopy. The next important modality of investigation is a CT scan or MRI. This radiology is advanced in a very tremendous way. They can find out where exactly the obstruction is, how much is the severity of obstruction. There are different angles, and the expert people will tell you how much obstruction level and how much you need to intervene that area. Then coming to important issue, this is how where we can get a subjective thing that will point us towards disease. Now, exactly what is called as polysomnography. This is where sleep study, or in short, we can call it as child is allowed to come to us to the clinic of sleep apnea clinic, sleep study clinic. He has been attached so many wires like ECG, microphone, EMG, EOG, thoracic belt position, and so many things are attached to a machine, and it interprets the data during the sleep, how many events of apnea, how many events of hypoapnea, choking, how is the child behavior is there. So let's see how the polysomnography, this is a not a actual picture, this is a animated picture. You can see this is how the different, this is the breathing efforts are considered, brainwave activity, noise level, heart rate, blood pressure, and this is the airflow. This is all been tracked, and you can interpret this thing a different manner. So this is how the normal flow, if it is a normal flow, see the different patterns of there, this air is coming normally and there's not creating any issues here. But flow is limited, that means early obstruction is there. Here is the obstruction level, noise level also just increases. There's a bit increase in the heart rate, and there's not much thoracic and abdominal breathing efforts are there. But when it comes to the obstruction, that means here soft tissue is already touched. Here is creating vibrations. Here the noise level has increased, brain activity has also increased, and breathing efforts, still it is normal because the child is not in a apneic phase. So if this, you have to, they automatically is a computer based device collects this data, and next day when the child is going to coming out of sleep and you are analyzing the data, you monitor this, how many episodes of apnea, how many episodes of hypoapnea, how many episodes of choking, how many episodes of hyperventilation. So this is, for example, this is apnea. This is a total choking here. It is not going, and if this remains for 10 seconds, 12 seconds, child gets aroused here, heart rate increases, his blood pressure saturation will go down, and child will have very hyperactivity kind of thing, and then he will start taking tachypneic or labored breathing, try to bring level his oxygen saturation to the normal level. So this polysomnography remains important objective tool to assess a child with snoring. You get a lot of information in it, and most of the time, most of the places, at least in a city, you have 1 or 2 places, usually ENT people have, or sub-tertiary care centers also, sleep studies test centers are there. Now you are diagnosed problem related to snoring. Now you have to treat. So how you are going to treat? The treatment part is, so it is a practice pathway. The European Journal of Pediatrics has published this in 2010, almost 10 years back. So this was they were contributing mainly to the adenoid hypertrophy. Snoring child was with mild tonsillar and adenoid hypertrophy. So syndromes related to, as I discussed, craniofacial dysmorphism or neuromuscular disorder, they have to find out. If it is there, then you have to go either polysomnography or home monitoring is there. If there is no sleep apnea, you are going to observe the child. If there is sleep apnea, you are coming towards a operative thing. Then other associated lot of concurrent treatments like or problems are there. That means you have to ask the child to reduce his diet in calories and fat to control the obesity, some nasal irrigation, nasal steroid, but it's not a definitive thing. This was suggested antibiotics for chronic sinusitis. Then there are different orthodontics treatments for keeping that narrow maxilla. If it is still persisting, then they were going ahead for adenotonsillectomy and they were following. So this was almost 10 years back. So anything recent evidence is there or recent guideline is there, because everybody wants to treat these children according to their way of management. But is there any standard guideline is there to treat these snoring children or obstructive sleep disorder breathing? So snoring is now, as already told, considered as OSD, obstructive sleep disorder breathing. And this is published in 2016, the task force of ERS, and this is a statement. And I'm with the next few minutes, I'm just going to treat, because treatment is the most important pivotal part of snoring management. So step one, you have to do with the child at risk of SDB. 1 or more, if symptoms of upper way obstruction, findings of examination, like I already discussed, objective findings on imaging, and either history of prematurity. So this step one is pointing towards this child is likely to SDB, and if obstructive symptoms are not there, you are going to monitor, or you are going to frequently ask the child to bring to you, and you are following his growth and other parameters. Now, next important is step 2 is recognition of morbidity and condition coexisting with SDB. That means whether the child has become morbid because of snoring related issue or sleep disorder breathing. So blood pressure, pulmonary hypertension by measurement and echo. Then as we discussed about inattentiveness, cognitive disturbances and behavioral problem, enuresis is there, or whether there is overall quality of life is disturbed or not. Then coexisting condition, other coexisting conditions like metabolic syndrome, oral organ dysfunctions, recurrent wheezing is there or not. So first step, after first step and step 2, you have to go to step 3. It is called as a recognition of factors predicting long-term persistence of SDB. That means you have to find factors, or you have to search for those factors with whom you are more judicious, or you are more vigilant about these children. That means if there is obesity or not obese, but their BMI is growing, BMI increasing over the period of time. Male children, then obstructive episodes, apnea, hypoapnea index, will not go details of that, more than 5 episodes. Then African American ethnicity and untreated tonsillar hypertrophy. These are the children where you are predicting a long-term persistence. That means these likely to remain in SDB for long time. Then we'll come to objective diagnosis and assessment of SDB. So I already discussed PSG or polysomnography if the child has risk of SDB. So more than 2 episodes or obstructive apnea index more than 1 per hour will classify as a severe SDB. So what if and more than 5 episodes are unlikely to resolve spontaneously. And these childs are at risk of morbidity and you have to intervene them. Sometimes it is not possible or not available polysomnography, then you have to do polygraphy, nocturnal oximetry, sleep. If it is still not available, there are different questionnaires are available. Then there are sleep clinical record. You ask the child to record, parents to record his sleep patterns, his apnea and snoring and all this. But polysomnography is required for as an objective tool. Then coming to step 5, what are the indications where you are going to treat? So AHI more than, this is apnea, hypoapnea episodes more than 5 per hour, irrespective of presence of comorbidity. If it is morbidity is there, then definitely like somatic growth affection, cardiovascular system affection, central nervous system affection, or decreased quality of life, or other associated risk factors are there more than 3, then you have to do an intervention. If risk of SDP or is not available, then you have to go by pulse oximetry. Is all of us, because of COVID, we are aware of this pulse oximetry, and anytime saturation drops in the sleep, usually saturation in the sleep drops below 92 in the deep sleep, but if it is going 90 with episodes of snoring and choking are there, then definitely is a indication to treat. So there are still guideline has not mentioned about what to do about primary snoring, and they have still mentioned that you have to evaluate the child annually or 3 monthly, 6 monthly, according to the grades of severity and according to the parents' anxiety. You have to keep these children on track. So this is how the step 4 is there. Now next 6th step is actual treatment. So how we are going to treat? So first and foremost is a change in the lifestyle, weight loss, overweight of these children you have to lose. Then nasal corticosteroids and or with Montelukast. So you can give a trial of 6 weeks of oral Montelukast, 4 milligram less than 5 years of age, from 5 years to 10 years, 5 milligram, and above 10 years you have to 10 milligram per kg. With or without antihistaminics, if antihistaminics can be added if the child is already having allergic rhinitis kind of disorder. And there are different nasal corticosteroids preparations are available, fluticasone, budesonide, and with other local antihistaminic agents are there. This you can try for 6 to 12 weeks. If it is not persisting, then you have to go for adenotonsillectomy. Word of caution here, adenotonsillectomy you cannot do as a just trial basis. That means as child is snoring, just go for adenotonsillectomy. It is not like that. And there are a lot of reports and all that, and adequate data is there that whether the adenotonsillectomy will really benefits in an early stage, that means stage 1, grade 2, grade 1 or 2 and tonsillet hypertrophy, it is still not clear. So it is not an empirical kind of therapy. If it is a severe, you have documented things on imaging, flexible endoscopy, then only you should go for it. Next other important issue is not in our domain. It is actually maxillary expansion and orthodontics appliances. This pediatric orthodontist, this is the domain, but you should clear-cutly document it that this is definitely a maxillary restriction and expansion is required. Then comes the role of CPAP or NPPV. This is for usually considered for obese children, obstructive sleep apnea children, and nocturnal hypoventilation to provide nocturnal hypoventilation. Then there are a lot of complicated craniofacial surgeries are there, and in like for example tracheostomies, because too much apnea and all. This is mainly because they do for neuromuscular disorders, neuropathies, and myopathy. So this is step 6. Then coming to step 7, this is a very important thing. Outcome is monitor after intervention. That means you have done some kind of intervention in the form of adenotonsillectomy, facial surgeries, and all those things. You have to monitor. So you have to monitor from 6 weeks to 12 months. You have to monitor the symptoms. You have to do maybe once in a 2 months of polysomnography. You have to ask about quality of life, other parameters of cardiovascular and central nervous system. You have to see the growth, and More than 6 weeks after until tonsillectomy, if symptoms are persistent, then again your post tonsillectomy also you can advise nasal corticosteroids, and sometimes we call it as a medical adenectomy. It is called as a very high dose, short acting deflacort kind of thing for a very short period. That is called as medical medical adenotonsillectomy. And nasal steroids you can continue for again 12 weeks and see if still persistent, then you have to, these children, you have to go for oral appliances and expansion and all those things. And airway re-evaluation should be there by, as I already told, by nasopharyngoscopy and drug-induced sleep endoscopy and MRI. So usually within 6 to 8 weeks, the edema and everything comes down, and still child remains continuous snoring, or there's no clinical improvement is there. Then you go for again this follow-up investigation modalities I already discussed. A bit word about just we are coming to the concluding session. I think 7 minutes or 7 or 8 minutes are there. So NIV is coming in a very big way in managing obstructive sleep apneas. Cost is less. Devices are family friendly or user friendly. Even in cooperative children, more than 2-3 years children now, this all these attachments are also patient friendly and child friendly are there, and they can themselves sometimes attach, but it's a very rare as far as Indian scenario is concerned, because limitations to the machines, their use, familiarity with this. And important point to remember here, as already mentioned, before pre-op for very short period of time, maybe 24 to 48 hours, for if you're planning for a chronic, very large resection of adenoid and tonsil, and after extubation also, you require this kind of NIV therapy. This is short about how we are going to diagnose, investigate, and treat risk factors and all that. Can we prevent? This is a $1 million question. You might ask me, can we prevent snoring? Yes, it is possible to prevent. It cannot able to totally, but some steps you can, these are not actually prevention of snoring steps, but these are steps to overall keep ourselves in a better kind of life, or improve the quality of life. Sleeps on the side, then maintain the body weight. You should not, because children are following you, if your as a parent body weight is increasing, you have no moral right to restrict the body weight of a child. Then regulating the diet patterns, preventing the junk foods, preventing and ask them to do a regular exercise, reduce time towards mobile and TV watching, different sips of water, adequately keep them hydrated, taking prescribed medications in the full term. So whatever your pediatrician have or ENT surgeon have asked you to take, for example, Montelukast and all that, they have to take for a very long time. Then ensuring positive airway pressures, swimming, exercise, outdoor playful activity. Now COVID season has gone now. All of us are free to do that. Dressing according to the weather. This can be very trivial thing also, but an important thing to maintain, and maintaining the hygiene. I would like to emphasize on sleep hygiene also. So you should not have too much light, too much noise at sleep. It is called as sleep hygiene. Dim light, proper, there may be some cup of milk to the child before sleeping. They should not watch TV and other mobiles showed before sleeping. And the easy induction of sleep. There are different noises are coming, called as white noise and pink noise. These are different noises are coming, and this also can soothe your sleep, and early induction of sleep can be possible. This is just to, and that these all measures can be applicable before taking intervention, at the follow-up, and for a routine child also. These are not specifically for snoring child. So to conclude, what we can talk, or what we can conclude remark is, snoring in child is definitely a red flag, even if primary snoring as associated with a lot of issues related to behavior and psychosomatic things. So snoring is becoming now new entity called as label as obstructive sleep disorder breathing. And it is a part and parcel of this big syndromic disorder, as it affects physical and mental health and ultimately a quality of life. So needs to be treated early. You have to go to the pediatrician early. Neglected snoring can lead to very serious health issues and comorbid conditions. Polysomnography remains the objective tool for snoring assessment, and snoring SDB can be effectively managed with stepwise approach, as now evidence-based medicine and guidelines are there. So there should not be our own way of treating. We should follow the whatever available evidences and guidelines are there. And not only treating, but regular follow-up of all snoring children is required before treatment and definitely even after effective treatment. So this how the snoring shortly I've tried to give glimpse about how the snoring is affects and what are the how you should able to manage. Again, at the end of my lecture, I would like to thank Kolhapur Medical Association about giving me this opportunity, and Dr. Amol Kodalekar specifically for giving this interesting talk, interesting topic to discuss with all of you. Though it is a trivial thing, snoring can lead to a lot of issues. So thank you very much.
Thank you, Dr. Vinayak Patki sir, for speaking on such a different topic. Now I would like to welcome Dr. N.J. Karnesh sir, and I will hand over to Dr. Sancheti sir for giving an introduction of the speaker. Dr. Sancheti sir.
Yeah, I'm hearing you. Dr. N.J. Karnesh sir. Good friend. Sir, welcome. Sir is going to speak on doctor's appeal to CK, medical profession. Sir is spoken in 300 national and international conferences. Now, sir is the president of Pune Orthopedic Association. So also secretary for Maharashtra Orthopedic Association, an executive committee member of Hospital Management Board. So also he's a managing committee member of Pune IMA. Sir has also done a great work in medical legal forum and now a chairman for medical legal expert committee. So I request Dr. N.J. Karnesh sir to enlighten us on his talk on saving medical profession. Please, sir, take over. Thank you. Karnesh sir.
Thank you, Dr. Sancheti sir, for my lucid introduction. First of all, I thank Kolhapur Medical Association, or IMA Kolhapur, for inviting me for this talk. And I thank office bearers, especially my very good friend, the president of Kolhapur IMA, Dr. Kodalekar, and his colleagues. Well, this is a little different topic. I'll just make a full screen now. Yeah, the consumer forum problem is increasing day by day, and what we see is only one-sided picture in the society. So I thought that we can have what doctors feel about all these things, and what is my observation for the last so many years that I decided to talk here. Well, first we'll go from the basics that in given circumstances of the infrastructure and affordability in Indian scenario, most of the doctors are trying to give best possible treatment to the patient. We have utmost respect for the judiciary as well as the members of the consumer forum. Doctors don't have any intention to criticize these highly respected institutions. So whatever I'm going to say has come out of the observation from the last many years. Just a minute. Verdicts of the last few years, somewhere there is a gross disparity in the actual cause and the grievance and the actual reason for which the doctor has been held guilty. Now, this might have happened because the lawyers may not have pleaded adequately, and maybe that doctor wasn't aware of the importance of the certain non-medical issues. Consumer Protection Forum was created to protect the consumer from cheating by the vendor in quality, quantity, or the cost of the product when he buys from the vendor. Later on, the service sector was also included in this. Incidentally, if lawyers are not included in this, it is very surprising. This act was a great relief for a common man to address his grievances. It was necessary because everybody has to abide by the law of the land, irrespective of his position and stature. We also agree that everybody has to follow the basic norms in the service sector also, including healthcare. We agree to that. But there are some black sheep in every field, and they should be found out and punished to maintain order and discipline. Doctors are supposed to be the intellectual cream of the society, toppers in the academics. They do the huge study, hard work, total dedication of more than 10 to 15 years to become a consultant. Real earning starts at the age of 35 years. When I started practice long back, around 35 years ago, I started at the age of 25 years. But now it takes almost 35 years to start earning. Doctors are trained and always try their best to understand, analyze, and diagnose any situation and follow the procedure meticulously. In practice, most of them are honest and try their best for the society as well as the patients. They are one of the most law-abiding citizens. Especially in recent pandemic, doctors have risked their own life as well as their family members' life for the treating the patient. This CPA should, consumer forum or even the judiciary should understand. Now, I have found that they are considering all doctors as the same, but it's not so. There was family doctor concept when the doctor was a sort of family member. Now it is almost outdated, and doctors are considered as the service providers. They are termed as healthcare service workers. There are differences between the general practitioner, what a consultant can do, and what is the setup of the super specialty. Again, there are different pathies like Ayurvedic and there are problems of the cross pathy also. Recently, we are facing all those problems. And important thing is that there are different kind of the hospital which CPA should understand, and there is a huge difference in the basic pattern of these hospitals. The more there is change in the technique, more equipments and more infrastructure, there is huge increase in the cost. On this type of the hospitals, we will see basically very shortly, there are corporate hospitals, trustee hospital, government hospital. In the crux of the medical profession, there is a small to medium nursing homes. First, we see corporate hospitals, which are run by the corporate sector, and they're having set like a shares and the corporate management, just like any other company. They give advanced facilities. There is 5-star ambience. There are state-of-art equipments, high-end equipments. There are many specialties under one roof, and multiple doctors, the staff are involved in the treatment of the same patient. But in the whole this system, the doctor is a very small part. This is preferred mainly by the VVIPs, influential persons, and the rich one. But such kind of care is required, such advanced care is required for very small number of patients. Hardly 2 or 3% patients require such a high-tech treatment. Instead, in this hospital, there is no personal attention, and the actual treating doctor is seen very rarely. They work mainly for the profits and the dividends. There is no question of charity. And it is in these hospitals that you find there is a huge bills, not in the nursing homes. The bills in the tune of 5 to 20 lakhs rupees. And people don't understand that out of this very minuscule amount, it goes to the doctor, because the society, media, everybody holds doctor responsible for such a huge bills. Here in this corporate hospital, the doctor are nothing like a bonded slave, labor like a slave, and they have to follow management policy even if they don't agree to certain things. An average man doesn't find anybody to address his grievance, rather he feels lost in the corporate hospitals. When in the trustee hospital, because the government cannot provide or had not been able to provide cheaper and the good quality healthcare, the trustee hospitals were formed. These are run by the private trust on the, really speaking, no loss and no profit basis. They are supposed to treat 10 to 13 patients free of cost. Also, they are supposed to serve purpose of the treatment of the cost-effective and the best quality treatment to the patients. In return, they get a heavy concession on all the taxes. They get a cheaper land. They get a more FSI for infrastructure. One hospital in Pune has got almost 11 FSI for their infrastructure. They are supposed to implement all the government schemes like Ayushman Bharat or the Mahatma Phule Yojana, but unfortunately, it's not seen so. Generally, here also for the patient, it is same situation like corporate hospitals. Patient doesn't understand the difference between the corporate and the trustee one. Trustee is the one where the cost should be minimal, but it is not so. Now the crux is the government hospital and the PHC. These government is responsible actually to provide the reasonably good health care, minimal cost to the citizens. The citizens have got the right to the health, but it is the responsibility of government. But unfortunately, government is spending hardly 1.25% of the GDP on health, as against 10 to 15% by developed countries. We are low, fourth lowest in the world about the GDP which is given for the health sector. And another part is in real life also, all of us are knowing what is the situation in the government hospital. Even recent fiasco of the Jumbo hospital is known to everybody. Because the government is not able to treat the epidemic, they have to take the help of the private sector. And this is actually failure of the government. But doctors are held responsible for these management failures. Everywhere we see the doctor is so and so, in this hospital, doctor has done so and so. Obviously, no celebrity, no VIP or no affording person or no politicians, they take treatment in the government hospital. Rather, it is a common belief that those who cannot afford are going to the government hospitals. Now, the main is a small and medium nursing homes. The 80% population is treated by small and medium nursing homes. Once upon a time, this was the dream of every consultant, every doctor. But now we find owned by a group of the doctors. Here, on one side, we have to follow the nobility of the profession, but on the other side, government forces all the laws of it is an industrial establishment. Second is that we have to take a commercial land and infrastructure which increase the cost to more than 200%. Here, they have to follow all the government rules of the labor, pollution control, bio-waste management, and FDA and whatnot. They have to pay all the taxes as compared to trustee hospital. The taxes were applicable to lawyers, CAs, and architect. And these other people are not expected to do the charity, but doctors are expected to do the charity. Then doctors have to follow all draconian laws of government, like CA, Epidemic Act, MESMA, etc. Rather, just yesterday we found that UP government has made 10 years government service compulsory after the post-graduation. Otherwise, they have kept the penalty of 1 crore rupees. It is not so for the lawyer, CAs, or the architect. Here in nursing home, the bills are much less as compared to corporate hospitals, sometimes almost to the 25%. But the most important, patient gets personal attention and the affectionate treatment. And this is the crux of the medical practice in India, which is getting severely affected by CPA. Doctors in the small nursing homes, they are trained to take the utmost care while treating on the medical grounds. They learn all the latest knowledge. They hone their surgical skill. They keep themselves updated about the medicines also. The science updates are rapidly exploding, though so these doctors have to remain student forever in their life. But when they study all these things, not in a single curriculum, it is not taught what medical legal precautions have to be taken. And doctors are not taught what laws are applicable to them. They are not aware of them unless they get tapped into that. They are not taught how to do hospital management and what is ideal consent. Most are learned from previous judgments after some doctors are penalized. But here, the peculiar thing is that this vicarious discharge, it is a very funny word. Here, the doctor is held responsible for anything which is happening in his nursing home. Even if the sister gives wrong injection, even if there is something wrong with the food also, the doctor is held responsible, because then if the doctor is held responsible for everything, it seems that in nursing home, they have to stop now such facilities. Here, doctor is continuous in the stress. He has to work Ram Bharose. God, something should not happen in a hospital, because he is responsible for 24/7 by 365. Here the doctor's medical dilemma comes. During their training, as I said, doctors are taught definite protocols and guidelines for managing any medical situation, surgical situation. Doctors wish to abide and follow laws in best possible ways, but there are no definite medical guidelines, how to write the documents, how to do the communication. Even for infrastructures also, infrastructure is built according to norms of the local body, like municipal corporation. Here they give this infrastructure is adequate for treating a given patient. But doctors are not sure whether this particular infrastructure is sufficient for treating the patient. In the court of law, the court decides what you should require and what should have. Now here, MBBS doctors are allowed to practice. This is about the degree. But there are no definite guidelines that what is the cross-specialty practice. Especially, I'm not talking of cross-pathy, it is a cross-specialty practice. That whether general surgeon should do the kidney stone or not, or whether it should be sent only to urologist, whether the orthopedic surgeon should operate the spine or not, or it should be sent to only spine surgeon. Because if it's followed strictly, then MBBS, what patients MBBS going to treat? Because for everything there is specialty. Or even as I said, when general surgeon should not operate any, because there are super specialists for everything. So that is how the judiciary decides who should operate and what. Now, the most important is that there is a difference between the doctor and the carpenter or the professionals, because in professional, the nature doesn't come. But while treating the doctors, the nature comes. because the nature doesn't follow human laws, and there can be unpredicted result or the turn of the events can occur. Treatment of a patient involves many things. There is a diagnosis process. There are different investigations necessary for coming to the diagnosis, and all may not afford all latest investigations. And sometimes diagnosis is not possible in spite of all known methods of evaluation. Still, there is a dilemma. This CPA should understand. Doctor then treat according to the procedure decided by the current medical science. Sometimes certain symptoms can show much later up in the management. So there is a dilemma in the diagnosis. Now imaging like X-rays, ultrasound, even MR also, they can be we can say ambiguous, especially biopsy report, because we rely on the biopsy report and we treat the patient. And in these reports, these are nothing but the interpretation. MRI of one person may read differently, another person may read differently, and human error is possible. Sometimes the diagnosis is obvious, there is nothing required for that. But in few cases, when there is a gray zone, there can be different interpretation even by the experts, especially for the biopsy report. Because there was one case in the Nashik that the biopsy report, which was done by the laparoscopic lymph node, was removed, and that came as a Hodgkin's lymphoma. So the doctor, surgeon, and the medical oncologist started treating this according to Hodgkin lymphoma. But when the patient went for the second opinion to Mumbai and Tata, they found in the same slide that is the acute lymphoid reaction, which is a benign condition. And so they sued the doctors, other this laparoscopy surgeon, the treating oncophysiologist. They have to also pay almost 5 lakhs rupees because they treated only based on the biopsy report. That this judiciary doesn't understand. There is another part is on a differential diagnosis, because we can't, sometimes there cannot be pinpoint diagnosis. Even though the final diagnosis is going to be only one, and out of this, when one proves correct over a period of time, which has happened in this case, in that circumstances, is it that all remaining are criminals? They are treating them like a criminals and they are punishing them because the diagnosis did not prove correct. Error of the judgments can be there in all professionals. Rather, we can see in judiciary. While treating the patient, doctor considers basic minimal investigation. He doesn't go for all the investigation where the patient gets headache. The doctor has got, they see that they have got minimum basic facilities and try to give the best possible treatment in the least cost. It is not possible to have ICU with every nursing home. Doctors are trained for giving emergency life-saving resuscitation, but further continuous management ICU is necessary, and this happens exceptionally. Rather, in my 35 years of the practice, out of more than 1 lakh patients, it has happened only 9 times that I have to shift the patient to ICU. But we have found that doctors have been penalized because he operated a patient when he did not have in-house ICU. So if judiciary feels that for every surgery ICU facility is mandatory, and if it is implemented strictly, the whole healthcare system will break down and all the nursing home will be closed. The glimpses of it is observed in current COVID epidemic. What is our healthcare system? How much fragile is that? Because right now also we have got just 5% ICU available than the actually required one. Another part is that when a thief acts, his basic intention is criminal. But when a doctor acts, he is not basically criminal in nature. Irrespective of the oath taken, even if he doesn't take the oath, still he has got an intention to cure or give at least relief to the patient. So when the patient comes for a treatment to the doctor doesn't have any criminal intention to spoil the patient. There were days when doctors were confident that when we have done medically perfect management and when the desired result has not come, still rather we won't be suffered. Sometimes further management is required for a particular known complication. So you do something known as osteomyelitis, again it can recur, but it doesn't mean that the concerned doctor has done negligence during the previous treatment. Complications happen during treatment by everybody, whatever his competency, his knowledge, or his qualification. Somebody says that I did not have any complication in my life, then either he is lying or he doesn't have any practice. Because this fact is very well known in medical management. Medical treatment is not just like a machine, that every machine which comes out of the factory is going to be the same. And the results of the given treatment are predictable. This CPA should understand. Now there are many lacunae in the existing knowledge of the human body. We can say that we have understood very little about human body. There are many researches that are coming up. Sometimes response from the patient can be unpredictable. It is all probability. There is nothing like 100%. In the patient himself, there are a lot of individual variation. The effect of the one drug may be different in different person. Same drug may not act in a certain patient, while in others it can give excellent results. Similarly, it can have complications. There may not be complication in some patient, but in some patient there can be side effects. Here, fracture fixation also can heal the fracture in most of the patient. But in some, the healing takes very long time. Even if the fixation is very good, it takes months together for the healing. And while some patients, healing doesn't occur at all. even when treated by medically, so it has sometimes second operation required because the patient's body is not responding there. It may not be necessarily the fault of the doctor. There are limitations in the medical treatment that CPA should understand. It's not like it's like a classroom. The teacher teaches same to all the students in his class. In the same class, the some excel very brightly, they come in the merit, while some fail miserably. But because the concerned parent has paid the same amount of the money, parents cannot expect and demand the same result from that failed candidate. And the judiciary doesn't punish the teacher for the failure of the candidate. But here, if the result doesn't come, the judiciary is now punishing. Again, about the error in the judgment. There are in every field, even judiciary, there is error in judgment. When a court finds the accused completely guilty, a particular court, then while the higher court finds the same person not guilty and releases the accused. Now, is it that when the higher courts overrule the judgment of the lower court in toto, lower court should be punished for error or wrong judgment? But when same thing happens in the medical field, the different law is applied. When one doctor finds error in judgment, the previous one is punished. Because and known complication in the science is taken as a negligence. The judiciary says the reasonability is required, but then who decides reasonability? Actually, it is the expert committee who is supposed to decide it, not the judge. Again, in the expert committee also there are limitations. The forensic experts are expert in the forensic science like homicide, suicide, rape, etc. in the medical jurisprudence. They and some members of the expert committee are basically administrative in nature rather than academic. They may not be aware of the new techniques in that particular field. Science is rapidly expanding. There is a grassroots changes in norms. Even in the COVID, the norms are changing every month. So whether doctor has done any fault or omission or certain commission, only expert in that particular field is going to decide that. Say, for example, case of bilateral TKR, the doctor was punished because he has done TKR at the same sitting at Kolkata. Rather, there was severe punishment. And his registration was also cancelled for 1 year. And the judgment was given by the very old person, very respected person from the West Bengal state who had never done TKR in his life. And he said bilateral TKR should not have been done in one sitting. So it is totally wrong because that is done by, even we had done the bilateral TKR in one sitting, and judiciary cannot punish only on the report of that particular person. So that is the problem with the expert committee. Even in Pune also, one of the renowned cardiothoracic surgeon, there was some other patient died on the third day, even though he has done surgery perfectly correct. But the forensic department person is saying that he has done negligence. How the forensic department will come to know that whether the topmost cardiothoracic surgeon in Pune has done mistake or not? So there is somewhere something, there is a bias or the jealousy. So better to take from association, opinion from the association, either at state level or the national level, for mainly academic bodies. And in spite of that, even when the expert committee gives a verdict that doctor is not guilty or he has not done any negligence, still the judiciary has been given power to override that. That is called as Bolam rule. Now the judges are deciding whether doctor has done correct or wrong. Another part is on humanitarian ground. Now it is a vague. That patient has got complication, patient has died, so it is humanitarian. But why doctors are punished for that? It is all, we can say, God's will. Now here, especially the Supreme Court, the Western norms are read. Okay, Western standard may not be reasonable for our Indian scenario, especially when the doctor is practicing at periphery. Now, not to operate if there is no accreditation, not to operate if there is no in-house ICU. As I said, one should not do joint replacement if there is no joint replacement OT. The quality of the infrastructures is totally different in India. There are basic civil norms which has to be followed. But then one cannot have everywhere 5-star operation theaters in all over India. Then government has recently in Pune it has happened that all nurses should be the GNM. Now we told the authorities that you provide us all the GNM which are required in the Pune city. There are not adequate number of the GNM. Then how we are going to appoint them? So that is how the certain rules are there. Another part is there a difference between the qualification and the experience. The most of the nursing home doctors are knowing this, that they are having OT assistants who are hardly 12th standard or even sometimes 10th standard pass out, but they are masters and they can help in a great way. But if some OT nurse comes which is recently passed out, she may not be knowing the ABC of the operation theater. And all of us know how the qualification of the nurses is given these days in certain private nursing colleges. Another part which I said that Western norms of the spine surgery, that spine surgeon should be done by the spine surgeon and not by orthopedician, that we can't apply here. Rather, I did most of the surgeries as the spine surgeries. Again, the same thing as I said, then the general practitioner or general physician cannot perform any treatment or procedure according to Western norm. Now, the important part of the documentation, we fully agree that adequate documentation is necessary, but there are no guidelines anywhere what is adequate and how much is adequate. Even the minor lacunae, the date, the signature, or the, you can say CT all every day, and the minor investigations has not been sent, then the doctors have been held guilty for that. One of the cases in the National Forum was almost, I say, 15 or 20 lakhs punishment was given because the hematocrit was not sent. Now, the most important part is the consent. Now, for every blood transfusion, you have to take a separate consent, and you have to mention the rarest of rare complication in the consent. Now, even if the complication occurs, doctor is not held guilty, but he has not written in that particular consent that this complication can occur, then he is held guilty. So remember, now when I was in Germany in 2000, there I saw the consent was almost 6 pages. I laughed at that time that what funny things are going on here, because we were taking consent of almost just half page. I'm ready for all operations. I mean, all and complications are known, and all anesthesia, any kind of anesthesia can be given. But now it is seen that why these 6 pages are required, because you have to maintain every rare possible complication during anesthesia, during operation, and even a post-operative period also. Even the late post-operative period also, what complication can occur, you should mention everything into that. Doctors is sued for alleged negligence in medical management resulting in death or undesired result. Now, desired result cannot be there in every patient. And doctor is punished severely and extremely, not for the negligence in the actual medical management, but for a minor lacuna in the documentation. And that is not correct, because out of the 1,000 scenario, if one thing is found, then the doctor is guilty completely. Now, is it that, now, suppose recently, rather in many cases, if that particular complication was not written in the consent, and that complication occurred, so doctor was held guilty, and 5 lakhs, 10 lakhs, 15 lakhs compensation was given. Now, what I want to ask, whether the doctor has written that particular complication in the consent, that lacuna has been fulfilled, and then the doctor is not negligence, because even if the patient is dead or complication has occurred, but because he has written in the consent, he is not punished. But he is not written in consent, he is punished. So, what is important? Medical management is important, or this kind of documentation is important. So, doctor has to pay more attention to the what documentation they are doing rather than what treatment they are giving. Most important part is the quantum of punishment. There is no specification about the quantum of penalty for given error. So suppose some signature is remained, how much punishment you are going to give, or how much compensation should be for a minor omission in the consent, or even if the consent is not taken, how much is serious is that? Even after taking utmost care, and if the minor investigation is not done, doctor is held guilty. Even there is a clerical error. All gynecologists and radiologists are seen in the PCP and DT that they forget to sign on any paper, or they have not filled a particular space. They are held guilty as if female infanticide has been done. I mean, there is but both are considered the same one. Many times we have found the huge penalty as compared to error while treating. The quantum of penalties are already very high, and with the current changes in the CA, there are tenfold increase in the practice. Now, with the district commission was giving maximum 10 lakhs punishment, but now it has gone to 1 crore. For state commission, it has gone to 10 crores, and for Supreme Court, it will give penalty more than 10 crore. Now, don't know how much more than 10 crore. So it seems now it will be practically impossible to practice now. A small error in the documentation can ruin whole life of a very successful doctor. So what is the future of the healthcare? The doctor has to pay more attention to medical risk than the medical risk itself. Doctor has to take legal care and concern because thinking of medical issues or what are the medical problems. One of the most important reasons for increased number of the expensive investigation is this, because if one investigation is not done, he is punished. This fear among the doctors is not addressed. Those who have choice will go to other fields. The doctors will, even my own son has left medical field. Once upon a time, the talented cream of society was choosing medical field. All the toppers were saying either we will become doctor or engineer, resulting in high quality care of the society. But now there are more of a capitation student, private medical college students than merited one who sought admission to the medical life. So in future, on one side, there will be more commercial hospitals where the doctors will be just employed of the slave, while on the other side, there will be only government hospitals to get the treatment from government of that quality. Result, what result will happen? Individual doctors will not be seen. Individual small and medium nursing homes will perish over a period of time. And who will get suffered? The common middle class man will suffer seriously. But its effect of on the society will not be seen now. But around 20 to 25 later, it will be seen, and then it will be too late. Thank you very much.
Thank you very much, sir, for a, I would say, wonderful presentation. And you had started with long things about the customer being cheated, lot of things. And
doctors are considering
doctors are treated just like criminal. So I think
yes, sir.
And they are punished. If for a small mistake, I would say there was no sign on the consent and challenging about whatever has been done by a surgeon or maybe a general practitioner, that you have said that we have to pay the penalty of 1 crore or more. So we have to go for indemnity insurance and a lot of things. And as you said, small and nursing hospitals, they will be closed. That I would say it is a bad scenario for all of us, including might be a rural or urban center. Because if this hospital closed down, it will be, I would say, really difficult for a common person. Even a middle class person can't afford. Other, he has an option to go to government or maybe to corporate hospitals, and corporate hospitals will reap their benefits. And doctors who are working there, as you said, they are working like slaves. It is quite true, very unfortunate, and we have to also look into. I tell all the delegates that Karne sir had stood up. Whatever there is a problem for any of the general practitioner or the colleagues, they have stood for all of the doctors and taken, I would say, good steps that the doctor is freed also. We have a medical expert team in Pune IMA also, and sir has a lot of contribution along with Dr. Naurange sir. So I request all of you to see that all the hospitals, small hospitals, they should also survive, and middle class people should also, I would say, take the government to task that you have to look into sympathetically. You have to have a team of experts, those who stand for the doctors. Now, cross-pathy and other things, we don't want to discuss about the things, but the thing is just like divide and rule. Whether we were standing united before, now that scenario has changed a lot. So I request all of the delegates on all of these stalwarts who are there, that it is a serious time to look into the scenario of all of the doctors. So thank you, sir.
Thank you very much. Thank you.
For presentation. So also now I'd like to thank Dr. Abasaheb Shirke, the president, the Dr. Pillai madam, Dr. Sheetal madam, Dr. Amol. And all the, I would say, team of Kolhapur. I am IMA Pune Secretary Dr. Rajan Sanchandi, giving a good opportunity to be with all the members and delegates from IMA Kolhapur. Thank you, sir.
I just want
Thank
to
you,
mention
sir.
one thing, that all my school education has been in Kolhapur from 4th standard to 11th standard. And from 12th standard, I was in Miraj till my MS orthopedic.
So
for 17 years, I was in Miraj and Sangli Kolhapur area. That is my,
Dr. Shirke,
mother
Dr.
place.
Shirke sir is your classmate.
Classmate, MBBS classmate, yeah.
Yeah. Thank you, Sancheti sir. Our last speaker, Mr. Dipen Mehta, who will be speaking on digitalization of medical records. Mr. Dipen Mehta.
So I'll introduce Mr. Dipen.
Yeah.
Dipen Mehta, good friend
Please
of mine,
introduce,
and being advisor.
Okay, sir.
He's the COO of DigiShield software company. We call it Cyber Computers. He carries a decade-long experience in operating and controlling critical businesses, financial, maybe pharmaceutical, and a lot of issues. These people are having about 60 to 70% business in US, and they are providing, I would say, a lot of support to all our IMA. I think all over Maharashtra, I have seen DigiShield is doing good work, and the person involved is Mr. Dipen Mehta. And so also Mr. Sanket is looking after all these 1,500 people's team, and they are doing a wonderful job. And I feel they are supporting each and every of the IMA from district level to rural place also. They are looking after, and they will have a lot of support for our doctors. So I request Mr. Deepen to take over and enlighten us on his work of DigiShield. Please go on, Mr. Deepen. Thank you.
Thank you, Sanjay sir. Thank you, IMA Kolhapur. Thank you, Dr. Amol. Thank you, Dr. Shirke, for giving DigiShield opportunity and managing technically for this wonderful webinar. I will help doctors to understand what the benefit of the digitalization in current situation. As when we compare India with the foreign countries, in foreign countries, more than 95% of the healthcare industry have adopted some of the EHR softwares. But in India, we are way like behind with compared to foreign countries. India, we see as per data, only 30% or less than 30% of the healthcare workers or hospitals and clinics are adopted some of the softwares. So why there is a difference in India? Why there are many of the challenges in India which they are facing. So one of the major challenges, initial capital requirement for the small or medium scale hospitals doctors for computers, laptops, and servers backup. Another challenge we see is the implementation process. It requires a huge implementation process for the doctors for adapting some of the softwares. So the doctors are currently used to write the paper and the prescription and hand over the hard copy to the patient. So which I find difficult for the doctors to adopt the new technology and new software because of the complications. They find it difficult and they doesn't adopt as the softwares. Even there is a lack of computer literacy for the doctors as well. The doctors are not so much techno savvy. So when it comes to adopting some technology, so doctors get frightened and they are not very comfortable and useful to adopt some of the softwares. There is a lack of awareness of the among the doctors as well in Indian doctors, as many of the doctors doesn't know the what are the benefits, what are the policy of adopting EHRs. So doctors doesn't use or adopt technology or any softwares to maintain their digital records or maintain patients' lab reports or any of the medical history. So what are the benefits for the doctor if the doctor starts using or adopting some of the softwares or EHR? So what will be benefit for the doctor is they can have a timely intervention of their medical records. Whenever or wherever doctors are there, they can easily access their patient's medical record. They can view the patient's medical history, patient's reports, everything, each and every medical record can be viewed by the patient, and it's required up-to-date and complete information of the patient's health information. The patient's medical record can be accessed 24/7 as it is securely stored in the backup, which will have eliminate the risk of the mislead of the patient's report, which is in the paper prescription. So even doctors can have the de-identified information of their patient for analytical and research purpose. Even doctors can be able to view the number of times their patient visited, the number of patients visited per day, what are the patient's previous history, patient's previous medical records. Everything can be viewed on the go by the patient, by the doctors. In many times it happens that doctor prescribes the prescription with the paper and hand over the paper to the hard copy to the patients, and have doctors to visit patient after 2 days or after 5 days. But after 5 days, what happens? Many times patient forgets their paper prescription. So in such situation, it finds difficult for the doctor for further medication. So if doctor are using any digital platform and if patient forgets the paper prescription, so there is no risk or no issue for the doctor and the patient. Doctor can easily view their previous medication and the previous prescription of the patient. So which helps to doctor and the patient as well to maintain the relation and increase the relationship between both the both the doctors and the patient. So, and even in current situation, because of COVID, many of the doctors are doing video consultation and teleconsultation through WhatsApp or any other medium. So in such cases, there is also risk for the doctors. What if patient has done the video consultation and doctor shares the prescription through the WhatsApp, and patient doesn't pay the fees, consulting fees, or forgets to pay the consulting fees to the doctor. So in such situation, in DigiShield, we have developed one feature which is a health pay, in which a patient doctor can do teleconsultation or video consultation through the app. And once the video consultation has been done, doctor can share the prescription to the patient, and patient will receive the SMS link of the prescription, but patient will not be able to view the prescription unless and until patient pays the consulting fees through online. So if patient clicks on the link, patient will receive the error or pop-up window that your so-and-so consulting fees is pending. Please pay the consulting fees to your prescription. So in such cases, once the patient will make the online payment, then only patient will able to view their prescription. So in such cases, it's risk-free for the doctor as well for their consulting charges. Now, if suppose doctor has done any video consultation or want to do teleconsultation, so there is no need even for the patient to use any smartphone or no need to download any application. It's a small SMS patient will receive from the doctors, and in which there will be a short link. So patient just need to click on the link and they can do a video consultation as well. So DigiShield has various other features. DigiShield can book patient. Doctors can book patients' appointment. They can schedule patients' appointment. They can even send a reminder, a follow-up visit SMS to the patients. Doctors can do teleconsultation, video consultation. Doctor can even maintain their patient's medical record. They can even upload their previous medical record, lab reports, or any pathology reports. Everything can be uploaded to the patients, and each and every records can be viewed by the doctor for their patient. Many times what happens that if there is a family patient or a very special patient for the doctors, and doctors maintain each and everything for that patient, and the patient is of diabetes, and doctor recommends the patient to do HbA1c for every 3 months. So suppose after 3 months, there is a due date for the patient to do HbA1c, and doctor forgets to have the patient to do HbA1c. So if they are doing the maintenance record through DigiShield, so even doctor can get to know that so and so is the due date of the patient's next HbA1c test. And the software is very easy to use and very handy software. It can be used through iOS as well as Android. I will just share you a short 2-minute video as how DigiShield can be used and how it is benefit for the doctors.
Download the DigiShield app from the Play Store or App Store now. New users will go through a quick one-time registration process. After filling in some basic information, registration is complete and you can start using DigiShield. Logging into DigiShield is easy, safe and secure. Enter your registered mobile number. An OTP is sent to your mobile. Enter the OTP and you are logged in. No passwords to forget. Making a patient's appointment is easy. Just click on the calendar sign, enter the patient's name and mobile number. Select date and time of the appointment, and that's it. A confirmation message will be sent to the patient, and so will a reminder. A day before the appointment, your patient will be automatically contacted by the DigiShield agent. The Shield agent will collect the patient's symptoms, history of present illness and more. The agent will also collect any consents or indemnity that you want to collect from them. Based on the DigiShield interaction, you will be alerted to the patient corona carrier risk. It's easy to do a phone or a video consultation with the patient. DigiShield recommends that patients that have been flagged with a high or moderate corona carrier risk should be consulted via consultation first. Click on the phone icon or the video icon to do a safe and secure teleconsultation with the patient. In order to issue an e-prescription to a patient, tap on the pencil icon, tap on the camera icon to take a photo of the prescription, and you're all set. The prescription is sent securely to the patient immediately. DigiShield is easy to use and you will be online within 5 minutes of downloading the app. Download DigiShield on the Android Play Store or Apple App Store today. Protect yourself, your patients, your community. Download DigiShield for free today.
So as you can see, it's very easy for the doctors. You can download it from Android as well as App Store. The software is completely free for the doctors for the lifetime. So would recommend doctor start downloading and start using it. If you have any queries, you have any issues, you can contact us, and you can even call me, or you can even visit our website www.digishield.me. Thank you.
Thank you, Dipen
Thank
ji.
you, Mr. Dipen.
Madam, please take over.
Thank you, sir. Good afternoon. Very good. We had a very good discourse today on different subjects. At the outset, I would like to thank our delegates for waiting patiently because we had a small delay in the starting of the program. I would like to thank our esteemed speakers, Dr. Ajit Kulkarni, Dr. Vandana Agarwal, Dr. Madhuri Lokapur, Dr. Vinayak Patki, Dr. N.J. Karne, and Mr. Dipen Mehta. I would also like to thank our President, Mr. Abasaheb Shirke sir, our CME coordinators, Dr. Amul Kodolikar, Dr. Dumare, MMC Observer, Dr. PM Saugule sir. I would like to thank our sponsor, DigiShields, Mr. Dipen and Mr. Sanket for sponsoring the program and being our technical partner. I would like to thank our CME coordinator, Dr. Rajan Sancheti sir also. I would like to thank our office attendants, Abhijit, Anand, Bhale, Santosh. I would like to thank Vishwas and his team for initial coordinator of Zoom. Once again, thank you everyone. I thank Dr. Sancheti for helping us out today.
Most welcome.
Okay.
Thank you, sir.
Okay, thanks, sir.
Be seeing you.
The
Thank you all of you. Thank
meeting
you.
is over. Thank you.
We'll leave now.
Yeah.
Thank you.